No, the guys just said this one.
Oh, for introducing people. This one's for the room.
Oh.
Do I need a red and a black one?
I think I just need all the help I can get at this point, but okay. Good morning, everybody. Good morning. Thank you so much for coming out and making it safely. And I was talking with a number of you this morning about we would prefer heavy, slushy snow as opposed to our light, fluffy, slick snow. And then that made me think, well, we're just snow snobs, right? But no, thank you so much. I do know it's a hassle to drive. We have some of our rural partners here who made the effort, and so thank you so much for doing that. It's always a hassle to park. So I know it may seem easy saying I'm just going to go to a training today, but there's a lot to it on snowy days. So thank you very much. Really appreciate the effort. We are going to be very flexible today. And so at the end of my little spiel today, we're going to go around and we're going to introduce ourselves just very, very briefly. My name is Sharice Pope. I'm the director of something, and I hang out at Better Health Together. What we're trying to get an idea for Ann and John is what your role is within the organization, how many people from your organization we have, and then just a little sound bite about what you want to get out of today, like just a little blurb about, I really need to understand workflows with pharmacy, or I just made that up. But whatever it is, that's what we're wanting to know. Ann and John are terrific about really being adaptive to what it is you want and what it is you need. So that's what we're going to try to do this morning and today. And then I just want to, this afternoon we're going to be doing some actual workflow exercise, and I want to thank right out of the bat, because I'll forget this afternoon, Ponderay has agreed to be our I'm going to say star students, but I used the word guinea pig when I asked them this morning, and then that didn't go over so well. But they rallied, and they're going to be terrific this afternoon as we go through the workflow exercise. So. All right, so we're just thrilled to have Ann Shields and Dr. John Kern, again from the University of Washington Ames Center, with us. We have our friends from CMTV with us. Again, this is live stream. It's going to be posted on our website. And for those partners who are joining us remotely, Ann and Hadley will actually be doing your work and facilitating your work via Zoom in just a little bit. So that's for our remote friends. Everything that we hand out, all PowerPoints, all handouts, again, our recordings are all on the website. So anytime you or your teams want to go on there and take a look or maybe do something in-house, that's right there for you. So really encourage you to take advantage of our website. Just a couple of really just nitpicky logistics. Our restrooms are to the right if you go out the doors there. Those of you who know me, I live to roll my eyes, and so if your cell phone goes off, you're going to get it. You're going to feel the eye roll. Please mute the cell phones. We do understand if you're on call or something, you may need to take a call, but mute it in the room, please. For parking, we're going to have breaks, we're going to have lunch, so hopefully that allows for you to go out and plug meters if you need to. At the end of the day, we're going to have you fill out the bright orange survey that's in your packet. Again, really wanting your feedback in regards to, was this helpful, and what do you need going forward? And we do use the feedback, and we compiled that from January, used it for today, and we'll continue to do that through the process. So that is key there. And then my final ask, before we go around and introduce ourselves, is just that really, and this sounds like a teacher or a mom, and I'm going to point my fingers, really ask for you guys to participate fully, ask questions, give feedback. Ann and John are terrific to work with. We really, really have tried to make this pertinent and something that all of you are going to walk away with something with. And so But that depends on you folks as well. So we really just encourage you, be a participant, get all in. The folks sitting at all of you are really nice people. So if you're sitting with new people, you're going to make new friends. But just really encourage you to share and work together today. So with that, we're going to go around and we're going to introduce ourselves just real quick, name, role, and then what do you want to get out of today? I'm going to start with the, so this is the trouble table, and they all rode together, and so when they walked in, they were all kind of tiny bickering. So I'm just tiny.
My name is Mika Sato. I'm a Spark outpatient, and I'm a CDP, outpatient counselor. What I want to get out of this meeting today, I don't know.
Okay.
I'm here.
That's
I'm
okay.
paying attention.
That's okay.
Yes,
I'm Rhonda Kidney. I am the mental health lead at Spark Integrated, the co-occurring. I'm kind of with Mika. I'm here. We'll see what we get out of it because it's always a learning experience.
Okay, perfect.
I'm Linda Kruger, and I'm from Spark, and I am the programs coordinator, and I just want to learn what I've been trying to learn from everybody I've been sending because I've not been going. So.
I love how Spark's always very, very honest. Love that.
My name is Angie Landman. I'm Quality and Contract Compliance Officer at Spark. And I hope to continue to move forward with our PPTP and get that done and submit.
Okay. So that's their transformation plan.
Yes.
Yeah.
So I am Randy Woods. I also work for Spark. I'm the clinical supervisor, and I am joining the process kind of late, so I'm trying to catch up and learn some more information about what we are doing.
Okay, great. Thank you, Spark. Our friends from Daybreak, thank you.
My name is Sarah Spear. I'm the Director of External Relations at Daybreak Youth Services. And I jumped in a little bit late also, so I'm really excited to learn how the system's changing overall and how we can be a part of that. I'm Michelle Johnson, and I'm an administrative assistant at Daybreak. And I'm not sure I'll have an answer for learning today.
I'm Sandy Skoke, and I'm the treatment director at Daybreak, and I just want to learn more about how to put the transformation plan together and the differences between some of the tools that we're learning.
Okay.
I'm Rick Purcell. I'm Children's Home Society Director for Northeast Washington, and just learning how to better take care of our kiddos.
Okay.
I'm Teresa Braxton. I'm the mental health supervisor and crisis supervisor in Stevens County for the Alliance, and I'm just here as a sponge to soak up everything and do what my director tells me.
Oh. Wow, how did that?
Executive Director of the Alliance Counseling Services. So we're outpatient mental health and drug and alcohol for Ferry, Stevens, and Lincoln, and we're also inpatient mental health for Eastern Washington. And I'm tired of flying at the 30,000-foot level. So right now, whole person care for us means let's get a BMI and ask who the primary care is, and then it kind of stops. So we want to flesh out what this really means so we can implement a medical plan.
Okay, great, David.
Candace Holmes, I'm the mental health supervisor for the Davenport for Leading Alliance Counseling. And I'm also here to learn whatever you're presenting so that we got to write something. So I want to know what I got to write.
I'm Keith Spear, and I'm the supervisor at the Ferry County office.
Okay.
Of the Alliance. My hope to get out of this is to build our partnership even greater than it is with the medical clinics in our area.
Great, super. Thank you. Thank you very much. Go over here. Hi, Jennifer.
Hi, I'm Jennifer Larmer. I'm the Chief Clinical Officer at Lincoln Hospital in Davenport. We are rural. We're interested in continuing great partnerships and further enhancing those and assuring that we can get great services for our patients. So we're interested in anything we can glean and resources we can do that.
Great. I think I think you might be the only primary care in the room today. We do have primary care joining rural or remotely.
I'm Jennifer Stout, Clinical Supervisor with Monterey County Counseling. Mostly what a lot of people have said, I'm just here to learn as much as possible, absorb, and do what they tell me to do.
I'm Annabelle Payne, Monterey County Counseling also. I'm here to figure out how to submit a provider plan that's going to be approved. And implementation, like David was saying, and probably, is there any more money out there we can figure out how to get our hands on? So anyway, clinical director, that she's the director, by the way, in case I got missed. And I do whatever she tells me to do, but I would also piggyback on that we're really interested in learning more about data metrics, collection, and other systems in order to keep our funding consistent, because that is something that's looming on the horizon.
Great. Oh my gosh. Tough bosses is what I'm hearing.
Yeah. I'm Dale Cook. I'm the compliance officer for the Rise Care Centers. I also serve kind of camera operations at Center Cohort. I want to take a look at what we do and see how we can do it better and see how we may be able to integrate it if we're not doing it yet.
Hello, my name is Andrew Bingham. I'm the Behavioral Health System Navigator for Northeast Washington Educational Service District 101. We provide services and supports to the Tri-County area, Lincoln, Adams, Spokane, and Whitman. So let's see, what do I want to learn? So I'm hoping to have a better idea of where case management and case management needs fit into our provider plan, and how can our school-based clinicians start to do a better job of bridging that gap between behavioral health services and primary care needs.
Hi, good morning. I'm Brittany Campbell. I am the Assistant Director of Student Support Services at New ESD 101. So working closely with my friend Andrew here. And I am really just interested in how this transformation plan integrates into the school setting. So we serve 59 school districts, and we've worked in areas where many of you have already indicated, Perry, Monterey County, Lincoln County. And we typically refer up and out. And so we're kind of looking at a different model of how do we serve students on campus and really kind of wrap our hands around them in that way. So just interested to see how these pieces fit together.
I'm Ashley Sorensen. I'm also from UESD 101, and I'm the mental health representative, I guess, for our teams. And really, I'm just wanting to dive in with my counterparts on kind of our next steps, and talking about what that looks like kind of at the mental health level.
I'm Paula Keller, and I am with these folks. I'm with Northeast Washington Alliance Counseling Services, and I am the mental health supervisor out of our Cholula office. And I am hoping that somebody comes up with the secret to how do we get our local docs to, I mean, we're more than ready. We call, we try, you know, how do we get them to join our program?
So we want money, and we want secret sauce, and we want the answers, the magic answer. No, that's perfect. Thank you.
Misty Beard with the Riverside Recovery Center. We provide SUV services and MAT services for patients primarily in Spokane. Because of the rural people that do trucking, because they don't have it in the areas that they're currently in. The thing that I would like to learn probably would be just how to take the different expectations and pieces for making care coordinated on all sides and implement what we need and figure out where we've already got it down and focus on those pieces that are missing. I'm Stephanie Whithelm. I'm the Children's Advocacy Center Director at Partners with Families and Children, and I'm here to learn everything and anything.
Hi, my name is Laura Ross. I'm a mental health intern and MSW candidate working at Spokane Public Schools, mental health services. And so I just want to learn everything and anything.
I'm Jessica Bumstead. I'm the medical biller for the mental health program at Spokane Public Schools. I just would like to learn a bit more about how this model can be applied to our kiddos in the schools, how we can provide the best services for them.
Hi, I'm PJ Snyder, and I'm also with Spokane Public Schools. I'm the
lead supervisor and also other duties as assigned. We're a big agency as far as what we employ, as far as mental health therapists. Cover quite a few schools. We also cover Meade School District and Central Valley. But that being said, we're also a very small administrative team. So when I say other duties as assigned, I'm in the billing end, which is really fascinating to me because I don't know what they talk about. So all of this, it's all new language. And I think that's what I would like to really understand better is the language. I know we've done some stuff with the AIM Center. And what does it all really mean? And how do we put it into practice for our schools? It just seems so foreign to me personally. So.
I'm John Townley. I'm from YFA Connections. I'm the clinical supervisor of the mental health program. What I want to learn is really how we can improve our coordination of care and within the subsystem of care for our clients just to get better outcomes.
I'm Kathy Dorn, and I'm the CEO at YFA Connections, and what I'd really like to know besides how we track what we're doing is how to track what's not happening. So if one of the goals is to keep people out of the hospital, how do you measure something that didn't happen?
Good morning. My name is Tom Murphy, and I also work with YFA Connections as the Adult Treatment Services Director. And I would like to, like Kathy, for me it's gaining a better understanding of how we're going to measure these outcomes. How to identify baseline, and then, as clients work through treatment, how do we measure success? The other thing we're doing is developing our care coordinator position. So that's exciting because that's something we've never really thought about before, but we're going to definitely do it. And so, what does that position look like in terms of working closely with doctors and hospitals and clinics to make sure that the connections are being made?
I'm Pam Brown from Catholic Charities, and I like to lead with a cutting-edge, low-cost model to integrate healthcare and behavioral health into our myriad housing complexes, which serve the chronically homeless and low-income seniors.
I'm Gene DeRay. I'm Executive Vice President of Catholic Charities, and I think Pam said it all.
Pam was saying this morning she's going to go big or go home. So you missed that. You missed that in your introduction. I've always wanted Pam to say that.
Good morning. I'm Lisa Hartzer. I'm with Lutheran Community Services, and I'm the Quality Assurance and Improvement Director. I've been in that role for about 2 months, so I'm here to just kind of get a better grounding on where we're at with our plan and how we can better partner and develop some outcomes that are measurable and good so we can measure the right.
Good morning. I'm Rose Meany. I'm with American Behavioral Health Systems and the clinical supervisor at our mission facility and the administrator of our Scoping and Outpatient program. I'm here today because I want to learn more about our transformation planning and hopefully to get a good grounding with that.
Hi, I'm David Moliere. I'm the Executive Director for BHT, and frankly, I'm lost. I'm here to figure it out. I think the representatives from ABHS were new to this project, at least as far as, I think our names have been on it for a month or so, but we feel like we're behind, so we gotta get caught up and get moving forward. So I think today we're just gonna do everything we can and try to learn as much and get going.
My name is Ron Dockley. I am the Marketing and Outreach Director for ABHS, and I'm essentially just here to learn and absorb as much as I can and hopefully get some tips on how what we do can interact and work. We can work better with the people and the agencies outside of ABHS.
My name is Tanae Brooks. I'm a social work intern at Institute of Family Development, or WISE. So I'm just here to learn everything and more about what this is. So administrator for the Kalispel tribe of Indians. And I've been in this position for about 9 months now. I've previously worked at Lake Roosevelt Community Health Centers, which is the community health centers for the Caldwell tribe. And I was the executive director there for years. And I've been through the AIMS program and when we integrated behavioral health, and I really enjoyed it with that, with my previous group of employees, and I want to help my new staff at Kalispel through the process again.
Great, super. Thank you, Allie. Allie's also on our board of directors, so we are very pleased to have her. And I'm going to come back to Kate because Kate we're introducing ourselves, and you don't just get to walk in and go to the back. I know, you know how I roll. So name, position, and what you're hoping to get out of today, just real quick.
Okay. Hi, my name is Kate, and I work at the Institute for Family Development, and Danae there is part of my team. She's our social work intern, and I'm the clinical supervisor. So we're hoping to just get the good skills and information we need to implement all the Medicaid transformation and integrated behavioral health that we need to do on our plan.
Okay,
Thank
all right.
you.
I'll let you find a seat and get coffee now. So. All right, so I'm going to thank you all very much. That was terrific, and we are happy to have such varied and different groups with us today. And with that, you guys have your orders, right? You guys know what you're going to do today?
Let me do my intro. Though.
You're going to do your...
And then you give it to John.
Okay.
Thank you so much. Ann Shields, I met many of you last month. I'm a nurse by training. I'm over at the University of Washington AIMS Center. I just wanted to grab the mic to say, this is a really tall order, folks. We have two of you. We have David and Pam who are like ready to go, big, cutting edge, meaningful plan. And then many of you, really the majority of you said, we're here, we're taking baby steps today. We're here to learn. And what John and I will be, we're happy to change this agenda today to focus on things that you may have missed previously, because this is such an important time to be able to talk about this together. So the focus being on team composition, workflow, that's a great starting point to think about what your model of care should look like. You don't have to be ready to go big to get something out of the room, out of this today, but I just want to encourage everybody to raise their hand if we lose you, or if you think we're missing something that would be more valuable to you than what we're talking about right now. So Charisse and I talked last month a little bit about a TA bank, and we just basically introduced that concept. If you saw, we had about 15 minutes to talk about being available to individual organizations and partnerships to work with you separately, not just in the context of coming together once a month in person or on Zoom. I just want to reiterate that. It's not on the agenda, but for example, Pam and I talked today about let's do a little separate, what I'm going to call model of care planning. Not ready to really define things clearly yet. We want to test some options about who could be our partners. Do we build it ourselves or on our own, or we do this in partnership? Lincoln, Jennifer, you said sort of the same thing, I think, in some ways. What could this look like? Model of care or MOC planning. I think that those conversations can happen really well via Zoom between these in-person meetings, and so I just want to really encourage you to reach out to Charisse, and if I'm not the right person, we'll find you the right person to help you with that. ESD, Spokane School District, there's a whole lot of very strong behavioral health and whole person care programs over mostly on the other side of the state, but we're happy to help you connect those dots. We actually have a team at AIMS that's training in the mental health staff in those school districts now that stand up school-based health centers. So that's the kind of thing that we'll never cover in this room. But you can do that on an individual basis through the TA bank. So I wanted to just make that point here. And, you know, common themes here are really the basics of building team members, like case managers, care coordinators, that came up. Money, money, money. Anyway, so.
Great.
Thank you.
Great. Thanks, Ann. And so as I walk over to Dr. Kern, who's our next.
Could you want to hear from the people who are remote there?
Let's have because I'm just a little hesitant, so let's have the people who are participating remote. They are their own team today, and they're going to be led by Ann and Hadley, and we'll do a fantastic job. But before I hand it to Dr. Kern, our TA bank, we knew that we wouldn't be able to meet everyone's needs in this style or this format, and so that TA bank is available. If you have something specific where you're like, I want an hour, I want 2 hours, I need help with revenue cycle management, whatever it be, figuring out your model of care, that is what that is for. So you just need to literally send me an email, and we will find the right person for you and get you hooked up on that. Okay, so Dr. Kern.
So do I just have one microphone, right? I don't need this one.
You need that one and that one.
Oh.
So you are good.
Okay. Hi, everybody. Can you hear me through this? Am I on? No. I see the little green light. That's cool?
Yeah, that one's still fine. You want to speak to the audience?
Oh, very good, thank you. Okay, that's better. Hi, everybody. For those of you who hadn't met me last time, I'm John Kern. I'm a psychiatrist. I'm a faculty at the University of Washington, where I've been for the last couple of years. Prior to that, I was a community mental health psychiatrist for 27 years, and I ran a large community mental health organization and became very interested in integration both of primary care and behavioral health and primary care, and in taking care of helping keep alive my clients with severe mental illness and medical problems, and eventually created a federally qualified health center that our mental health agency merged into. So my, what really makes me get up in the morning are those two things. The spreading out, so I have a highly grandiose set of ideals, one of which is to make sure that people in need of mental health services actually get them. That seems pretty grandiose. And the other is making sure that people with severe persistent mental illness live long enough to achieve their recovery goals. So those, so that you were talking about the 10,000-foot view, or that's it. And so everything else is commentary and details. So I think it's helpful, and I think it's helpful to keep that reference point in mind when you're tearing your hair about the details and the rules and the money and how it all works and all these crazy forms. And so what we're going to do in the interest of moving quickly away from the 30,000-foot view is we're mostly going to be way down in the weeds today, talking about what the various kinds of plans that you can make in your organization to create, to sustain programs that achieve one of those two goals, either creating access for mental health services in your primary care organization, or for most of you here in the room today, the other way around, keeping your folks with serious mental illness, substance use disorders, or kids with SED alive, or assisting in that process. And I think I think it's been demonstrated that those are actually realistic things to try and do. And so, from my point of view, as I've said before, I am absolutely thrilled that this opportunity exists for this actually to happen, because we've been walking around saying this is an important thing, but now we can actually do it. We actually have I apologize to you that you're being basically forced to do this, but it's good for me. So anyway, So so that's what we'll do, and so we'll start talking about what this would look like. I've had the opportunity to chat with several of you individually this morning and last month, and and so you've chatted with one agency, you've chatted with one agency. So we're going to try our best to walk you through some of the steps of how this might be done, and then that's when we start talking, and that's when we start figuring out how we have to tweak a model, or how you have to tweak what you do to achieve a goal that gets you someplace. Not everybody's going to have the same goals, not everybody's going to be doing the same kinds of things, but doing something that's meaningful. I'm mindful of that, something that's meaningful. I'm also mindful, as a former mental health administrator, of the pressures to keep, to meet the marks you need to meet in terms of reporting, in terms of, meeting administrative requirements, in terms of money. And so I'm mindful of trying to figure out a way of doing all of those things at once, which it sometimes seems like it must be some kind of miracle. Talking to the Ponderay people this morning, we were talking about how you make staff appear out of nothing. We won't be teaching you that today, but I'm mindful that your solution is going to be different from somebody else's solution. Okay, enough about that. Okay, we just have one slide today. Oh, here we go. Oh, wait, no, it's off. It's on. All right. Yeah. Look, I broke it already. Okay. Thank you. All right. So we're going to, so we'll be using some of our multitudinous handouts today. We've killed several trees in order to help you think about the details of what a model might look like. And I was listening very carefully when everybody was introducing themselves and sort of saying, well, some of you said you're late to the parade and trying to figure out what's going on, so I'm hoping that this will be helpful with the details of that. And so these are the things that we're going to be focusing on. Is your organization ready? The answer to that is going to be universally no. It's not time to be ready yet. You're faced in the direction of being ready. And so one of the things we're going to do is walk through what we see as all of the individual parts of organizational readiness, and see where you're at and what you need to do and where you may need to change your plan or add to it. Do you want to do this part? Or I can, it's fine.
I'm happy to. I just want to say that whole idea of what your team composition look like, I realize that may mean you're adding one person.
Yeah.
You're trying to figure out, do you need a care coordinator? If you're going to get a care coordinator, one, why? What will they do that's different or in addition? How will they work with the rest of your team to support your client, the objectives you have for your partnership and to achieve whole person care? So it doesn't have to be a big involved piece today, but this is sort of getting into the weeds of why would we do that, how would we do it, and how are we going to start thinking about paying for it, okay? I thought it would be really useful to just kind of ask for sort of a high-level approach today. Except for Lincoln, we are, and some folks on the Zoom line, we're behavioral health agencies for today. Has anybody really thought at this point about whether or not you're thinking about basically building your own primary care capacity in-house? Maybe you've already done that or you're considering that. I'm just interested in kind of a show of hands if that's something that's on anybody's radar today. And okay, we got one hand. So it's sort of on radar, not decided yet. You're kind of unusual, yeah, because you definitely already are there. Yeah, you're already there for sure. This is really more aimed at those with less comprehensive services than you're able to offer as a tribal partner. So we got one show there. How many of you are working with a partner or trying to strategize how you're going to approach and talk to a partner. Can you put your hands way up? Okay. So that's kind of what I thought. Sort of the dominant theme today is not really building a team solo, but building a team through partnerships. How many of you are working with multiple primary care or other providers? So a lot of you are, oh, that makes it really easy, right? Okay. And how many are just absolutely undecided how you're going to approach whole person care yet? It's totally okay. Come on, Spark Table. Have you raised your hands? Partnerships. Okay, I'm sorry, I missed your hands. Okay, all right, well, that's good to know. John, I'm going to give it back to you, but understanding that what you're really talking about today is a team that's not just your team, it's going to be a team that includes somebody who's not in the room today, right? For the most part. So what we might want to spend a little more time on is digging into those of you who have maybe some existing partnerships like Lisa's, and talk a little bit and share what folks have learned who have started working with a partner. So, okay?
So we're gonna start with, I'm looking for the paper so I can wave it.
The checklist.
This is the one we want. All right, we have two. So what we're going to be starting with is this. This is it's called Integrating Primary Care into Behavioral Health Readiness Checklist Tool. And so basically what it does is it sort of walks one at a time through the kind of first level of steps to see if you've decided what you're going to do. And again, I hasten to point out that, you know, that for probably for 95% of you, this is not going to be talking about, you know, providing the actual provision of care. This is going to be talking about the monitoring and coordination of care, ensuring that it's happening. Those are the kind of tasks you're looking at.
So, John, there's a one-pager
And then
everybody has that has. You should all have a one-pager that one page that just is sort of readiness 10-point checklist, as well as the fill out the blank one. Do we?
Yeah. So it's the same. It's the same material.
It's the same materials, but they may have only one copy of one and one of the other,
Yeah.
and bunches of the others.
Yeah. So this one's easier to scribble on.
Okay.
So what we're going to ask you to do is.
You want to just describe it a little bit so they.
Do you have extra copies?
Yeah.
Yeah.
Let's
Yeah,
see what we got.
they're coming.
I'm not sure what's at the table. Yeah, there's extras.
Is this what you're looking at?
Yeah.
There are 3 per table. So they
Okay,
can work
there's
as teams.
okay 3 per table, and then did we make a copy of the one pager that has the whole checklist? Okay, it's okay. We'll be fine without it. All right, John, I can help you on this sort of.
Sure. I'm not sure you have mine.
So this is a milestones checklist. Before you dive in and get started on this.
Everybody has a copy of it.
Yeah, I know.
So there's 3 per table. Everybody got one. You can do this as a team with the people you're working with. You know, these are sort of, we developed this a year or so ago with the Washington Council and the National Council to think about what does a behavioral health agency have to do to get ready for the brave new world of Washington State Medicaid whole person care, right? So, so that's just sort of the background of this milestones approach that we wanted to give you some time to go through and think about, you know, what are the steps, because these are kinds of things you have to think through and be ready and address as an organization to move forward. So.
Okay.
Timing and stuff.
Right. So it's now 5 minutes to 10. So we'll go to 10 after. What I'd like for you to do is hobnob with your fellow wizards and see where you're at with each of these things. And what you write could include, for example, what you're planning, if you're not there yet, what you're planning to do. And so then we'll get back together and chat about where we're at with this. And you want to talk about, you want to do the scoring part after that? You want to orient them to that now?
Well, let's just get a read here. I don't want to push anybody beyond their comfort zone. Sometimes, if you were all a little further along in your model development, planning what your partnerships were going to be, I was thinking, okay, let's we believe in measurement at the Ames Center, so I was thinking, would you be comfortable rating yourself today? But I don't want to put anybody in a position if they're not comfortable doing that. So you could give yourself a pass on those 0 to 50 points if you want. But I do think it's useful for you as an agency to say, hey, we haven't even thought about this yet. I'm going to give myself a big 0 on this, versus I've actually got a pretty darn good plan in place, and we already have our partners. We're already starting conversations, so I'm going to give myself full points. So nobody's going to get held responsible for points, but I would encourage you to think about that kind of internal self-rating so that you stay on top of the work you have to do, the very hard work you have to do as an agency to start planning your own model and getting going and developing partnerships. So that's all.
Okay. Now it's closer to 10 o'clock, so let's go to 10:15, and then we'll chat about what we found out.
Yeah, we have a mute switch back there. So. Okay.
Sir, would you like to join one of the tables
wanna go
and
bother.
chat? We have room here. We have room with these folks. They're awfully nice. Back there with that's Catholic and YFA back there. So yeah, wherever. Oh sure, no.
Thank you.
No, you're fine. Yeah, just wherever you would feel comfortable, sir.
Get me to the right place.
Yeah.
Oh, sorry.
So for you three lone wolves, so would you mind kind of sharing the
Great.
and all of that stuff
Great.
is all in the building. And
Great.
when we're sitting there and the guy's rubbing his cheek, we just grab him and take him down to the dentist, and they'll see him right away.
That's great.
But nothing. I mean, we have an agreement with them. But then my other offices around the community, we don't have a doctor in.
Right.
You
And
know?
that's going to be more common, right?
Yeah.
And so so there's two layers. There's one is like there's a doctor, and they take care of your patients. And then but what we're talking about in sort of this whole health model is there, unfortunately, needs to be kind of another layer that you provide of just checking up. Of like, did that happen? Did they go?
Right.
Did they get their script? Did they fill their script? Did they take their medicine? Do they still live in the house with 19 smokers? Do they?
And that's where our company is doing this program called the Navigator. And Navigator, this is something we've been working on over the past year and a half before this came about. And we're just like, oh, well, that's what they're talking about is how do we make sure Billy goes?
Yeah, and so the whole
he's going to school.
So the whole purpose of registry and caseload tracking is just to guide the work of that either person or that team who needs to be taken care of first, second, third, and then when it happens. So I know you must do this. You have work to do. You call somebody you need to do something with, and you leave a message. You have somewhere a place where you calendar. You're going to find out, right?
Yeah.
There's a feedback loop. That's what this makes possible. This is what's missing from our care in general. These patients. This is feedback. Did it happen? And so there's nothing complicated about it. It's just a way of making sure it happened. And then did it work? And then there's did it happen? And then there's did it work? And you go, oh well, yeah, they went to the doctor and they took the meds and blah blah blah. But they're still hypertensive, or they still have asthma, uncontrolled asthma. In your case, that's usually the thing with kids.
Right.
Though you have these kids and they're on antipsychotics, and they're like.
Yeah, ballooning.
It's alarm. It's terrifying.
It is.
And so I see these children that we work with a different children's home. They're like, well, our kids, you don't have to worry about that cardiac disease thing because it's your children. It's like not accurate. And so a fat kid is going to be a fat adult. And
are you guys working with the Vancouver office?
We worked with the ones in North Central. I forget where they are.
Oh, Wenatchee.
Must be Wenatchee.
Yeah, because we use, I think one of your docs, we do the telepsychiatry through one of the docs at the U.
Ah, yeah, cool, yeah. And they did, you might talk to them. They did very good work.
Yeah, and we're all part of the same company, and that's
Yeah.
the thing is,
Yeah, talk to
we're
the-
trying to do it here at the same time that we're trying to get all of our offices statewide on the same.
Yeah. Talk to them. They did some very good work. Hey, you guys. I'm John.
I'm Sarah.
Sarah.
I'm Sandy.
Hi, Sandy. Hi, Michelle. Sandy.
So we do a lot of this internally at Daybreak because it's an inpatient. We
Oh, you're
have a
inpatient?
Yep.
Oh,
We
okay.
have
So you're a whole
medical
different.
clinic.
Like, I gotta like.
And we're youth. We're youth inpatient.
Youth inpatient.
Yeah.
Okay.
And ENT.
That's it.
No, we do substance abuse co-occurring. We have an evaluation and treatment for youth.
But it's
We
all
have an
acute.
outpatient. Yep.
Wait, you have an
Adolescent
outpatient.
girls. We have an outpatient out in the valley.
And then we have another facility in Vancouver.
Okay,
we
we're
need
not.
the TA, not yet, but eventually. Yeah,
Okay.
we need the one-on-one. Our biggest thing is like Sandy does a lot of this. We definitely need to strengthen some of the areas of tracking, and tell us if we're going too big once they leave.
We lose them.
Are they still your patient?
No.
I know that's where.
But see, we schedule in their discharges, their medical, their psychiatric, their mental health, their substance abuse outpatient appointment before they walk out of our building.
What's your average length of stay?
45 days for the SUD program.
We do have the
ENT,
Ys,
it's about
too.
5. Well, we have Ys,
Yeah.
but that's please.
We have a lot going on.
I have too much already.
Okay, so you're inpatient, 45 days, and that's it. 45 days and out. Nice knowing you.
Yep. Which is horrible. That's like,
and we get kids from all over the state.
And in terms of ongoing linkage with their follow-up care, you have like you have referral. So if you get kids from all over the state, you're sending them back to.
Yep.
And we make sure they have appointments. But my concern is, did they get followed through? Did they continue that integration?
Well.
So are we thinking too big?
Yeah, we want transitional living.
Kevin,
Okay. Okay, so let's back up. Let's back up. What's the point of this?
Other ideas? You're very welcome to.
Right. Right. So improve the integration with primary care.
Enough to
Provide.
drive a lot, and then I'm hoping
Okay,
to do a
so
road trip and meet all of
what
you up there.
so you're saying, and so in general, to be honest, the model for this is
That's going to make a lot more
a
sense.
community mental health center with patients that you see for 27 years, and they're like long timers, they're permanent, they're with you, and you shepherd them in terms of their interaction with the healthcare system. So that's not you.
No.
And so I think a really important issue for you guys, and I don't know the answer to this as we stand here right now, is what's going to be required of you. I mean, so there's like what would be good to do, and then there's like what do you have to do, and then you find your way between those. And I don't actually know. For an inpatient, for an acute care organization, in terms of, I'm sort of take this with a grain of salt. I'm sort of surprised you're here.
Well, no, we shouldn't.
Just keep typing at us here if that's working best. You can call in on a phone.
No. I mean that you're in the same kind of bucket as these other outpatient behavioral health.
The biggest problem, can you say about like what
because you
particular
have that's
staff
why.
positions?
And so there's some of these it's like it's like a shelter and they have a clinical clinic, so they count.
Or
So tell me about your outpatient part.
behavioral health counterpart. Can you say a little bit more? Like, talk about a particular position that you're maybe
I think we're missing Spokane Regional
So
Health
maybe that's what
District.
your project should be.
Does that sound right?
All about the money. That's right. And the budget. Absolutely. Yeah. So. So,
We need a TA with you guys. Figure out what do we actually do.
Yeah, I think the very first thing I want to know, just to put some structure on it, is what are you
Carrie, good heavens.
down the road? What are going to be the metrics or the requirements that you're going to be living under? So it makes no sense to set up a project tracking something, and then later on, we're not helping you. And then later on, in order to sort of get your money
I did
and
not,
keep
but I
full,
sure as
you
heck
got to be doing something else. It might be helpful when you're like, oh, this is how you spin up a program. But I've spent a lot of time thinking about this. I read the requirements that you guys are going to, and you have two sets. There's the ACH requirements, and then there's whatever
we
you're
even
going to have
have
under integrated
our
medical.
friends from Spokane and
Medicaid.
California with us today.
Do you know what's going to be under integrated Medicaid? No, neither do I. Nobody does. It's like you have to go to Fort Knox and break in, and maybe then. And so
Yeah, Alice said she's just here checking us out. So I said, you check out all you
your
want.
plan to follow all of your folks forever. I mean, that'd be great if you had like a grant to, but you're not going to have that.
Must require a licensed staffer to do in order to basically maximize your revenue out of it.
So and what you could do, and we'll talk more about this.
I know this is not a panacea for what you're up against, because you have a lot of workforce issues as well. But I do know, for example, some of the patient navigator positions around our state and also in Spokane County
Did you notice if Adams was on either? Vicky's on? Okay. Yeah, we are literally only missing the regional health district, which is bizarre that we're missing them.
As an example, for navigators,
they're in August.
Pretty tough crowd to work with, high need, high cost. But but there is a lot of training and support available.
Okay, then never mind.
But aren't licensed. Now, I know that isn't going to solve your problem.
So 100% of these 40 kids came from where did the rest of them go? Okay. So you're in patient training. We'll do you no good. You have to do some kind of health training.
administrative or clinical leadership has to really work carefully to very carefully
So
define
you're,
those
you're two
roles,
people.
so that everybody feels that their role is
I'm
valued
just
and
saying, it's
respected.
not a big.
But if, for example,
But
you've
the
got
reason you're here,
So,
non-licensed case manager,
oh, Jennifer's
not a
coming.
big. So bring it
able to work more directly with the issues around
Okay.
making sure that
You're taking care of this
primary
10,
care
20,
is successful.
12, 15
It's fine.
kids.
So for the folks who are doing the Zoom with Hadley, and they will see when Dr. Kern comes back, or they're just doing their own period, right? Separate.
They're on the same Zoom as everybody else.
Great, and that might be considering that
And I'll
that might
Does anybody use
jump
a
up.
nurses
this
as part of their behavioral health team? That's another step. LPN?
and
Oh, yeah,
it's not going to, it'll be
great for
relatively
those
easy to the scale is so small.
Now, I understand that
Screening,
at this point,
screening,
pathways,
follow.
care
So you got,
coordinators, that's something that is
I mean, you saw
thought
that.
about, piloted, and administered.
Where's my buddy?
When here I am. So when you get your new grant and your clinic,
Our new grant?
your new grant for your new clinic. That's exciting. Fingers crossed.
Well, and Dave hasn't shared as much, so I'm not really sure. I know it's at Rogers. I don't know exactly what's the waiting for.
I asked about that simply because
Probably whether you got it or not. I bet.
So who did you
kind
like?
of mind had
Kaiser?
kind of mind
So
is
Kaiser's the one that's
available.
doing it. Wouldn't it be great to have
Dave
something like that?
Oh, it's like ACT.
A mobile? Is that
When
one?
I act is like in-house, team-based, intensive mental health care.
How great
Wow,
that
yes.
would be.
Heavens, yes.
Hey, we're having.
Oh, you didn't tell me that
I
part.
know.
Well, I think that's great. I just can't help but think that if you had a clinic at Rogers, God, that would serve the whole community because there's nothing there.
Right.
I think there's a Chaz on
Body of knowledge. And a lot
Chaz
of
is there.
Hilliard.
this kind of work
Yeah.
Chaz
is
is
part
Yeah.
of what they do. They
I'm sure they're.
I mean, how,
with these people.
what's
and
the
then
access?
they help them, make sure
Exactly.
it gets paid. They
versus
make sure
having
they
to
get
go
out of jail. They make sure they do.
Right.
And they make sure they get to the doctor.
Exactly.
Yay!
Yeah,
I
so
know.
that would be even better. How many? What's the census for your wives? You can handle that. And you're probably doing half of it already.
Adding to it, yeah.
How are you guys doing?
Right. And so what?
Good? Good. Oh, hi, hi, Christy. She can join on the Zoom too if she wants to do that. We're all so technologically advanced. I don't.
It's hard. I didn't know
Zoom
there
and-
was a Zoom option on this one.
Yeah.
I went to the website and just popped it in instead of like.
Right. Yeah. Yeah. No, there's a Zoom option for everyone, every learning cohort that we do. Yeah. As well as the live feed is all. You can always watch it on there too. So.
Which is great. It's
Yeah.
nice to be here though, so.
Yeah.
Once in a while though. Like yesterday I was on the phone all day.
Oh,
So I was
sure.
like,
I
maybe
know.
should interact with some people.
Maybe I should interact with people. Yeah.
It's hard so if you
Yeah. Yeah.
Okay, our question was about this one. The primary care provider identified to provide services on
The only
site.
difference between the Green Collaborative
So we're
and the
going
Collaborative Care
to
Model
create a
So,
pathway
is
for
in the
OUD.
Collaborative Care
So for an agency with a smaller client load, and all of them have their own
This is when you're doing behavioral health.
primary care, like it's not like one-to-one kind of relationship.
That's the difference.
Just how to work that way.
So I guess internally I would ask ourselves, do we have good enough
It's basically
either referrals or processes that when let's say because you guys serve kids, so let's say one of your kids is really struggling with their asthma when you go and visit them, right? Because you guys do a lot of in-home. So they're really struggling with their asthma, and you ask mom and dad, caregiver, you know, gosh, are they getting to their appointments? And they're like, well, no, we don't have time, or what have you. So do you have mechanisms to kind of connect with that primary care to say, look, we've been in the, just FYI, we've been in the home, little Johnny's really struggling, doesn't have their inhaler, that type of thing. So is your relationship that, you know, where
Do we
you
have contact with the primary care?
Yeah.
Okay.
Yeah.
And
That's
know what the resources are for our population.
Yeah. Right. Right. Yeah. You doing okay, sir?
Hmm?
You doing okay, sir?
Yeah.
All
Yeah, I'm
right.
just trying to move the slide backwards. Normally I can do this, but not in Spokane. How do I move the slide backwards? Look, it doesn't work.
I'm too old to make that. That's the key. Is you and I are too old to do it.
That's what it is?
Yeah. So
All right.
get a younger person.
Too old, too young to retire, too old to work the slide projector,
Pretty much.
as they call it.
That's where we're at. Yeah. Our overhead.
My carousel of slides.
Your
My
overhead
transparencies.
slide deck. So actually, Sarah will fix it for us.
She'll fix everything.
Yeah. We're not as cool as we want to be, and we can't do these slides. Oh, that's
Oh, I didn't see the Zoom. Okay, that's why.
that's why. Yeah, we're in this now.
I'll take notes on the report outs.
Sure. I got to talk to about 3 of them in person,
great.
which was extremely helpful.
Oh, yeah.
They're like, oh.
Yeah, not so well. But, you know, actually, a lot of people on the phone weren't at the, didn't cover the January, you know, it's money. It all came down to money. I got a little report out about the Pathways pilot experience and why it failed, which was good to know. Because I said, what are you able to mine? No, they didn't. All right, I'm going to just take
Okay,
notes.
very good. So we've got, yeah, let's go back one. You want to go back one slide? Good. 3 to 5. Okay. Did we decide they were going to report their score or no?
I gave it the option. Ask
Okay.
them if they
Do you want them to report out?
Yeah.
We have plenty of time.
Okay,
Let's
then
do
I
it.
will, when you get done, I will go around with the mic and we'll
Great.
have them do it.
Yeah, that's. You want to do it the same? We'll do that at the same time.
You took a picture of this, right?
I did.
Okay.
So I'm just going to say now we're going to report out, and you want to walk around and okay.
I need something to do.
Okay, don't go away. Okay, everybody. Okay, break time's over. Okay, so now what we're going to do is we're going to go around real quick, and for 3 to 5 minutes, I'd like to hear you talk about what you learned, if anything, from this process, and if you're more confused or less confused.
And we have plenty of time if you want to dive into anything, because we're ahead.
Yeah, and as Ann points out, we're ahead of schedule. I was able to talk with a few of you, and it was actually quite helpful in a few minutes to kind of talk about some of the questions that come up in the process of the report. So let's feel free to do that. So we'll just walk around. So you don't necessarily have to score yourself, but if you want. And let's hear about what you learned about where you're at and what you need to know. And hopefully by the time we get all the way around the room, we will have answered everybody's questions, and we'll have a delightful lunch. So, okay, Sharice, you want to walk the room?
Let's kick it off with Ponderay here. Well, you sat up front.
Yeah.
We didn't sit up front. We replaced it.
No, I blame Sonia.
So you want us to go to the exercise?
Yeah, hit the high points.
Okay, the high points. You guys have to help me with this. One of the things that we're fortunate, so we rate ourselves at 3 plus or minus. It kind of depends. Can you hear me?
Yes,
Yep,
much better.
perfect.
And leadership has been in place for quite a while. We feel very, very fortunate. Our partners, leadership has been very strong. We've had this vision probably since 2008 and just keeps kind of growing. In our county, we're also very fortunate that our commissioners are on board, which is huge. In fact, one of the commissioners actually is married to the CFO of a hospital, so he's a natural bridge, and he ends up being a great champion for us.
That's not a generally applicable strategy. I don't know what everybody else is learning from this.
Very well, I think is the.
You'll forgive me if you could focus on the things that are not there were questions as opposed to your triumphs, unfortunately.
Okay. Well, even today we're talking about clinical supervisors being on board, being ready, management team being ready. So these gals are very new, so they're pretty busy trying to even orient to the operations of the agency. And I'm thinking we're not alone in this because workforce is probably across the board. So you're constantly dealing with onboarding, orienting new people. At the same time, you're trying to figure out how you're managing all these changes, okay? So you're trying to figure out how not to stress folks out. And actually, for us, it ends up being a lot of discussion about dissemination of information. How much information do you put out there? So that, especially when the information a lot of times is, there's a lot of ambiguity. You really don't have definitive information. You're just saying this is the vision, we're going to go this direction, but we're not exactly sure how we're going to get there. And so that creates a lot of anxiety. Okay. What else? We might talk about this probably later today, but just even the nuances of some of the integration with our partners. So our largest partner is Newport Hospital and Clinic. So we've been doing a lot of meetings with them. So I say 3 plus or minus because we have a lot of theory and great ideas and wish list stuff going on. Okay. So I'm not sure how far down to the weeds you want me to get.
What most of us, I think, are going to find is that when you get on the back part, and these are later stage things, and for example, if you haven't figured out what your team is going to look like, you probably haven't hired them yet. So that you can, kind of stop it when it seems to make sense.
I would question might be useful for folks to hear. You say you're having lots of meetings. Who exactly is meeting, and what kind of agenda is it? How did you get that started?
Well, it started out of conflict. So a lot of people being angry at each other, why it's not working, and it's your fault somehow. So we learned pretty early on, we've really got to start having these dialogues, not talking at people, but talking with folks, so that when we get upset at each other, instead of saying, oh, mental health, you guys kind of, you're incompetent, you don't have a clue what you're doing. It's now a dialogue like the DCR comes on board and the doctor says, Pam, what's going on here? I don't understand, okay? So it's becoming more personal that way. And that's been a huge thing for us to have that, what do you call it, cross-pollination. Capacity and readiness is an issue for us still. So we have great partnership who might have a deeper bench, more resources, and yet they're waiting on us to get up to speed because they really need us to do the behavioral health piece, and yet we're really working hard on trying to get an EMR that's functional. Okay? Anything else you want to add? So I don't have to talk later this afternoon, right?
Yeah, you signed something.
Okay.
Great, thanks, Annabelle. So a 3 plus, 3 and working on it.
Yes.
Perfect. So, Lincoln?
I guess I'm nominated.
What's the
This is my CEO, Tyson Lacey, who wasn't here earlier to introduce himself.
Are we out of a 10 or are we out of a 5?
Yeah.
What's our
We're out of 5, right?
story?
Or did you want to go, we're going big or going home, so if you say 99, I think.
Well, we did not talk specifically about our score, but we were
us a pretty good form to bring those and address those pretty easily.
All right, so Dale with New Horizons, you mind sharing a little bit?
Sure. Okay, so for us, the first half of the page, we actually moved forward pretty well with that. And the fact that we have a lot to trim out of our plan, and trying to parse out what we're going to do. It's kind of difficult sometimes when you have multiple facilities with multiple levels of care, modalities, and to figure out how are we going to make this work in a way that's effective and sustainable. So the first part there, everybody's on board, but beyond that, what we're lacking. And one of the questions I'm trying to figure out is how, let's say from a residential piece, I might have somebody come in, maybe I'm going to see them for 14, 21, 28 days at best, and then they're going to discharge and maybe go do outpatient at Spark. You know, it's like, how do I track that person? I don't have an ability to track that person longitudinally, and then they're going to get care in other places, and we don't have access to that information. It's really complex for us from a residential piece to figure out how we're going to do this in a way that's effective and measurable.
I agree. That, I mean, as I was saying to somebody earlier, when somebody started thinking about how care was going to get integrated, they didn't have you in mind. No, I'm serious. When we started thinking about doing this, we go, okay, we have people with serious mental illness or SUD, and they're taken care of in organizations that take care of them over a period of time. That was the kind of classic community mental health idea. And then that's good. You have these people, you know them for a long time. You coordinate their care. Oh, beautiful. And then everybody should do that, right? Everybody should do that. It would be a good thing. It would be. But then you guys show up with your short-term model and mess everything up.
It is our fault.
Yeah.
It is our fault.
Do you have? And so you're not the only ones in the room. So are your services limited to short-term services?
Our services are limited with the MCO law. That's period. I have to justify continued stay after 14 days for every single patient, and their model really is a medical necessity, probably the least.
No, I get that, but your array of services at your organization, you'll forgive me, I'm not, okay. I don't know the organization.
Sure.
Your array of services do not include longer term?
They do. We have outpatient programs as well. Then again, it's kind of the patient's choice on where they want to go for care.
But they might say, hey, I like you guys, I want to stay with you guys.
We certainly try to do that, and I'm sure other ADS try to do that, and Spark tries to do that. We all try to do that. I think we can do better if they're kind of in our system because we know them, and if they fall back, they can fall back into our arms.
Yeah.
You know, and we already know where we're at.
So what I would propose is that as you're beginning to do this, that you might limit your integrated planning, your integrated service to those longer-term patients, to that outpatient service.
Fair enough.
And because I think that's the intention. As I was saying to somebody else, I don't think you'd be in this room. You wouldn't qualify if you didn't have a longer-term service. Is that right, Cherise?
So everyone here, they're eligible to be with us and in the project if they serve Medicaid individuals. So they offer a Medicaid service.
In any way, shape, or form?
In any way, shape, or form. Short-term, long-term, medium-term, high-intensity, low-intensity, it's the gamut.
I think that one of the things about these integration projects has been that the actual underlying intent has gotten lost. So as I said earlier, there's two major intents. One is the access to mental health services writ large, and the other is health for the seriously mentally ill and SUD and SED populations. So I think that piece of work for your organization would most rationally take place in your longer-term services.
Now that would make sense.
However, I knew this was coming just by looking at your face.
Patients that can start, let's say, come into the residential model.
Yeah.
They're not doing life well.
Yeah.
They're not really skilled at taking care of themselves.
Yeah.
We're kind of screening for things like diabetes, high blood pressure, smoking, that, and making referrals. So we're kind of initiating that process with them, and we do that already. You know, we kind of want them to be taken care of, but then when they transfer out of that system, I know that we can keep that information transferred effectively to our outpatient model.
Yeah.
It's making sure that, how do we get it to their outpatient model? How
How do we make sure that that information gets to them, their information gets back to us, and then we all track that? So if they go to their model and they're seeing another doctor, how do we keep track of that? Or
I think
is that
that's
your job?
If you have somebody in your short-term services and then they go to Timbuktu, in other words.
Great place.
Great, yeah. They go to Timbuktu services, they're in the back. Your aspiration is to see that their information, their care gets coordinated in Timbuktu, though you will never see them again because Timbuktu is really far away. Right?
Correct.
So I would say, somebody stop me, maybe that's too big a scope for your project. And you may decide that you want to do that just because you want to do that. But I don't think that's, stop me soon. I don't think that's within the scope of this particular, the requirements of this particular project.
Maybe I'm misunderstanding the eighth line item here.
All right.
Create a registry or caseload track to identify
Yes.
in order to track, process, and outcomes for patients on a caseload.
Yes. And so what I would propose is that what we're talking about is a registry of the patients in your outpatient service.
Perfect. I think talking with other people, I don't think we're the only ones that struggle with what that looks like, what that definition is, and what the expectation is. I think some of us have struggled with that quite a bit.
I also want to add, I'm the, practice coach thinker right now. We're also saying is start one place. Figure out the residential. You don't have to take the world on, right? Figure out your target population and your target program model and do that first. And then you start thinking about how the heck am I going to work with Spark?
Sure.
That would just kind of for everybody to, you don't have to solve everything in the next 3 months, but if you can be thinking about where you want to start and how, and make a success of that, then it's a whole lot easier to take the next step.
Fair, and that's if you've identified what our pilot sites where you have to do that. But it's having the mindset of not just focusing on this to the exclusion of that in the long term.
Right, absolutely.
Incorporated into the overall plan.
No, yeah, but I think that thinking of this as a pilot as opposed to a comprehensive long-term strategy is probably a good idea.
Fair enough.
And I salute your desire to do great things for the people that you see in perpetuity. Truly, I do, but it's asking too much of yourself, in my opinion.
ESP, what do you got?
I think this is really good. By that I mean exercise, not our sport. It's identified that we have had a lot of conversations.
Excellent.
And we've got a lot of conversations yet to go. I'm trying to wrap my mind around this in terms of 7 different clinicians that are going to be at 7 different locations. There are actually going to be 7 new locations come August, September.
Mm-hmm.
So yeah, more questions than answers. But I like this. I like the way that the milestones are laid out, questions that it's asking. I think a lot of work moving forward is going to be not just with this team here, but the larger team, including everyone at the administrative level and all the clinicians, and taking these next steps, talking about our goals. I mean, just sitting here, we already identified that for each of these, we're going to need to go through and list progress and success, next steps, options, questions, goals, barriers, and timeline. For
Yeah.
each, just that you
Yeah.
can start to wrap our head around those questions.
Yeah. So this is a kind of a later stage issue, but one of the things that's going to come up is you had mentioned multiple sites. And one of the things, so you're going to have some way, and we've been going on and on about how every place is different and but if you're an organization with multiple sites doing kind of the same thing in a bunch, you have to have some kind of standardization.
Right.
And it might be, and I'm just sort of thinking one of the things your staff is going to turn over, and then you're going to say, well, we trained everybody, and everybody knows about this, and everybody's down with this whole thing, and then somebody leaves and goes has a family, and then you have to hire somebody new, and they weren't served the Kool-Aid at the big team meeting, and so you're going to, and so I'm just
just thinking ahead, you're going to have to think about, maybe more than in some other organizations, standardizing what you do. This is our way of doing it. This is our form. This is our registry form. This is our intake. This is our medical screening. This is how we do it, so that you can do it for your 7 sites, and then you can do it when, clinicians 8, 9, 10, 11, and 12 show up.
Yes, actually, that's a perfect point, because one of the questions that we had the most difficulty with was that question of standardization, consistency
Yeah.
in the program.
So yeah, and I hesitate to bring that up because it's a later step. First, you got to figure out what you want to do before you standardize it. But
Right around the time you figure out how to do it, things change.
no, those stay the same always. If you don't worry about that, I'll be fine.
So our friend Dale here not only brought up a great question, but also brought up the issue of parking meters, because we are in downtown Spokane. So if you need to plug your meter, our great friend Smitri in the back has a pass, because we are a secure building. Many stories that goes behind that. So if you do need to plug the meter, we absolutely respect that. And just see our friend Smitri in the back. Thanks. And with that, we'll jump to our friends with the Spokane Tribe.
Sure. Great.
Thank you. Hi, I'm Shad St. Paul. I'm the program manager for behavioral health in this program. But Ricky Peelan had to step out. She's the health and human services director. We kind of came into this process a little late. There was some leadership challenges in health and human services before we started, and there was just things missed. We weren't responding to some of this Medicaid transformation. So we came in late. We got caught up. I think it's interesting when I see all the people at the table. And I always laugh when Jenny calls me. So how's your team doing? I'm like, oh, you're okay.
I'm good.
Yeah, we're doing great. Sure about the score. I would say almost everything is in progress with us. We have a primary care provider in our community, in the health services, so Roe-Pennant service area. We work with them, so coordinating services with them seems like the kind of no-brainer thing that we should be doing. Coming up with memorandums of understanding or agreement on how we're going to coordinate and communicate with, IHS is obviously looking at having a new EHR in our PMS system that they're using now is antiquated and irrelevant. We're in the midst of auditioning new EHR systems. We're all paper, so there has been an electronic health record implemented at this time. That's really a huge part of our plan. I think through that we can measure most of the things that we're looking at through the EHR right now. I would say that our program, we just go suicide initiative in our community, it's BHT 9 and GAT 7. We work with referrals back and forth. The system is, again, so difficult to manage. Things can drop sometimes. Managing people beyond care on the reservation is challenging, so a lot of people get EHR or emergency rooms in Spokane, down in Ward Caldwell. Do you mind making sure that have agreements with them? We really this time of that over a period of time, and there's still some avenues there. Relax, happen for a period of time like crisis coordination. That's kind of us in a nutshell. Like I said, most everything on this list, we kind of have progress. I think clinical supervisors, directors, clinicians, well, that's kind of the other people. So,
Okay.
we're doing pretty good on that part. Primary care, I think again, we started most of this. There's a couple that aren't in progress, and I think it's things that we need to start pretty soon. So carefully define team roles and responsibilities are certainly something that we need to. But again, with all the flux with the EHR coming on, it's hard to define roles because lots of things are going to change probably in the next 4 months. So we're kind of stepping back a little bit.
Okay.
Okay.
John, I'm going to just try to draw a few things that apply to everybody if I hear them, right?
Yeah.
So like we were talking pilot versus
Yeah, I was
taking
thinking
on
the
the
same thing.
world. The model of improvement here, the learning collaborative model improvement is, again, you start with a pilot. You focus in on a program or a site or whatnot. Figure out how that can be standardized, or what about it will apply to other parts of your agency. Otherwise, you will drive yourself crazy. You can't have 20 things going on with 4 different partners, right? If you've got workforce buy-in issues now, that's why that element of everybody handles certain kinds of data the same way is going to be important, for example. Then you spread. I also want to point out that I do not think the EHR influx is any kind of an excuse. I'm not pointing to you. I hear a lot of EHR development. But when we started a pilot for GAU, very tough, pre-ACH, all state funded, mostly homeless folks in 2 counties back in 2007, the rock stars in that work were the folks that didn't have an EHR yet, because the registry was such a great tool for them. It was the first time they were using a registry we developed, and they had a way to communicate between behavioral health and primary care through the registry. And some of the rock stars in that group were still not on EHRs.
Yeah.
So don't wait till you get through your EHR process to start thinking about other tools that your EHR is not going to provide for you anyway. Don't let that get in your way.
Yeah. Okay.
Okay?
Let's hear from you guys.
We've already touched on a lot of the pieces in here. There are a couple questions that will follow up to what we had already been discussing internally. So anymore to a fairly good start, considering there's definitely some of the details that we've got to get worked out, and writing everything down and getting it into the full policies and procedures that we want to have. The workflows were something that I actually really like getting that as an addition to policy and procedure to show the visual example. But otherwise, most of the conversations we started and already started building, so I think we're off to a fairly good start with one of the questions here.
Great.
So just need a little bit of direction on the details. So I do not score, but so I think we have some good foundation as far as buy-in and support from top management, and a lot of the MOUs that we have in place right now. I think it's a good relational foundation, but there are definitely some more things we need to do to really expand upon that and better define kind of roles and responsibilities within that. I appreciate, Annabelle, you were saying ambiguity equals anxiety. We're really working on mindfulness around creating trainings for our clinicians who are providing the work, because I think there's been a lot of anxiety about this for well over a year, and so we really want to make sure that our foundation and how we're going to do things, which assessments we're going to use, how are we going to track it, are all set and ready to go, so that way when we do present it to them, it's not this, but what is that going to mean then? So really trying to make sure we have a lot of that. So really looking at just better defining things for us, really looking at how do we want to track things, and then being able to send that out to our staff.
So I'm gonna pick on you a little bit, Stephanie. What?
John,
So-
could you use I can't hear you over here. Maybe just
Am I on?
grab the. but
Here,
the
I'll
mic.
use that.
Yeah, hot potato today.
Yeah. Okay. And so I'd like as much as we can for the rest of us to be as specific as possible. So if you say, we're thinking about what tools we're going to use, have you decided? No.
That's why we're in the process.
You're in the process of deciding. And when you're thinking about what, so just as an example, how are you deciding? What kind of things are you considering, and how are you making those decisions?
Well, I think the first is, what's our population?
Here, you hold that.
What's the population we want to track? So
Yeah.
we have an SUD program,
Yep.
we have a mental health program, and then we have some that are in both.
Right.
So really looking at what tools need to be utilized across the spectrum for those that may just be in SUD versus those who may just be in mental health. What are the core things that we're really looking at to look at readiness, progress, and true change? Where are they at with hitting those goals? And that's being
Super.
Okay.
Is that okay? Did they pass, Dr. Kern?
Yes.
Okay. So,
Lunch for you.
yay! So BJ with Spokane Public Schools.
So I'm going to kind of piggyback off you, Stephanie. I think we're in the same boat as far as trying to figure out really what is it that where we're at currently, I think, with our population. And we've been lucky that our intern here did a research project for us on kind of some measurements about how some of our populations, who we're serving, and where we're really doing well at. And so now what we're looking at is going further and what do we really want to target? What measurement tools do we really want to use? And what we're doing well to really kind of look at value-based reimbursement. I think those are the areas that we're really wanting to focus on. So we're starting those conversations around what kind of standardized testing that we're going to use. Because we have therapists that use everything. And really putting them in, maybe doing measurements like at intake, a little bit further down, and trying to get timelines in to where we can really take a look at how we're doing. So that's where we're focusing a little bit more on. And then we've had conversations on how do we bring primary care, or how do we work with primary care in a school system. It's been a challenge, I think, for us to really, how do we utilize that? We talked about can we utilize our nursing staff, and what's their work, their scope of practice. So we're looking at some of those areas too. Really, how do we coordinate better? Being a mental health system, we do SUD and mental health, behavioral health. So how do we do that and coordinate better with the whole person care? So that's us.
Did you find when we were doing that, when we were walking through this for 15 minutes, that you thought, oh, we should have thought a little bit about, we discovered something we should have considered in the process, or you're all over it?
I think we've had lots of conversations, and I'm sure ESD 101 has too, with Cherise, as far as it sometimes feels, being a school, it's very difficult. And how does this really relate to us? And how do we do this bi-directional care thing? And on one hand, I think it's really made us think outside the box. So I appreciate, I think, going through these kinds of things, because it also gives us the language that I personally don't have around the healthcare system. And so as we continue to go through that, I think we're one that want to do the technical assistance piece, because I think it will really help us be more focused on that. So did I answer your question? Or
Yes, yeah, you did. Okay. And from our perspective, having, for example, I certainly had no idea I was going to be working with schools and with ESD, and so that's what's.
Right.
No, it's cool. I mean, it's like I'm learning something about how, and there's no body of knowledge about how to do integration in a school setting, and so we're going to be it. We're going to figure it out. So I think that's a fabulous opportunity. So it's exciting for me.
They're okay? Dr. Kern, they passed? I keep telling BJ that...
They just coffee for you.
I keep telling BJ, you guys are going to get published. That's how because you're going to figure stuff out. So who from YFA? Kathy. Thanks.
We scored 62 points. Where we scored 0, and where we're having the challenge is establishing communication mechanisms. So right now what we do, every client that comes into treatment, we get a release for their PCP, and we notify them that we have one of their patients. And that's where we stop. So we're going to have to develop some kind of communication system, figure out who it is we're supposed to be calling, how we're going to get that going. The other place we scored 0 was we have no idea how
how to develop a registry or a tracking tool that's not an Excel spreadsheet sitting on the server that's prone to all kinds of human error and weirdness. So that's going to be our two places. The question number 2 that talks about well-informed staff, I get really nervous about talking to staff about what we're doing in here until we know what we're doing in here. So we scored a 1 because we're talking up here about it, but I don't want to be cleaning up all the exploded brains.
Right, that's what Kathy said, everybody's head would explode.
Right, they're going to explode when I say, oh, and by the way, besides all the other stuff you do, now you get to do this. So we're not doing that. So I guess that's our biggest challenge is the registry. And the other thing that is stuck in the back of my mind is value-based payments. We're going to be negotiating with the MCOs in about 9 months, and we have to somehow convince them using this information, somehow we're tracking something that they want to know, so that they will say, yes, we want to pay you money to work with us. And we don't know what they want to know. We don't know what they consider successful outcomes in behavioral health. No one has been able to define what is a successful outcome for SUD. So we don't even know what to measure. Luckily, our EHR measures PHQ-9 and will graph it for us, but so what? What's that going to do for us? What are the MCOs going to think about that? What do they want? So I need to set up a system while we're doing this that a payer is going to pay attention to.
They don't know what they want either, though. So
that's the problem.
Yeah, and I think at the moment the closest approximation you have to that are the metrics, are the BHT metrics.
Which is penetration for behavioral health. Get more people in. When we have a workplace shortage or a workforce shortage, get more people in. Our wait list is 6 to 8 weeks long. So you can't measure us against something we have no control over.
So, yeah, so I don't think that the only BHT metric is penetration.
They are the HCA metrics. So
Or the, well, I was thinking BHT because I was looking at your materials.
yes, so those are the HCA metrics. I love just shouting out, as you all know. So yes, Dr. Kern, they are the HCA metrics that we have.
So yeah, so that's probably the best guess. You know, if I was getting my agency prepared, that's what I would.
And I absolutely just am empathetic as I'll get out to these organizations who are trying to figure out exactly what Kathy says.
Yep.
I would also just look at what the MCOs are requiring in regions that have gone before you. They're not going to do anything radically different here. So you have that advantage of seeing what they've done in North Central and in other areas. Frankly, right now they're more worried about market share than metrics. They are. They want your contract. And they want you to, what the head of Molina integration says repeatedly, is we want to see movement towards whole person strategies. We're not asking everybody to be everything to their patients, but we want to see movement. So I wouldn't get too worried about it, but I think doing a little research on what they're doing already in North Central, King, and elsewhere, they're not going to radically change that template for you.
That's correct. And the MCOs do share with us if they are putting if they're going to put a metric into contract, so because they know that we're trying to support the organizations to be successful to meet. So if they do come up with metrics or expectations, they have, at least up to this point, and I assume they will throughout the Medicaid transformation, share that with us so that we can make sure we're not asking you folks to do anything that doesn't align with the MCO. Okay, I love Kathy's question. So now we're going to go big. I'm just going to call you go big or go home. So from Catholic.
GBG. Leadership's pretty well on board. It is, our agency does such disparate services, so it's been, and everyone has spent decades worrying about their own funding, so we're doing a lot of chatting, operationalizing some of these ideas about how to integrate our entire agency. It has been challenging. And as an ongoing working project across
facilities. Again, that's going to be a challenge because we've got such separate departments and everyone has grants and contract obligations, and so merging all of those and coordinating this might be a challenge.
Okay. So our friends from Kalispell, Allie, would you mind sharing?
Sure.
You were trying to warn her?
I'm sorry,
Is
I'm
that
like multitasking. Right now what we're working on is the patients, we just finished our patient-centered medical home assessment. I don't know if some of you are familiar with that. But when it comes to coordination in that, communication, we have extensive care coordination agreements. We have crisis plans with local, Conway County, Spokane County, the state. We have many communication plans. Our leadership is extremely involved in many different boards, from Better Health Together to tribal boards, local and statewide. So we do a lot of that kind of stuff as well. And right now it's just like working through the PCMH, working on, we're very, very lucky at Kalispell. We have a RN who, we have many people who try to contact us to work with us, and we have a RN who's retired, and she's of course a RN, can't sit home and do nothing, and so she's volunteering with us, and she's working on our registries to help develop those. So we get a lot of opportunities to work with a lot of different people.
Great.
Thank you.
Sure. And so do folks know what a patient-centered medical home? Are there any questions about that? If I don't see a hand, I'm going to assume you know and move on. Otherwise, I was going to make Allie tell us. But okay, you're letting her off the hook. Okay. All right, ABHS.
I've scored us in the pilot stage at a 2.1 out of 10, and that may be exaggerated, I'm not sure. I think we have some challenges that have been discussed. One of those, I've written down sort of 3 that were at the ground level, or the ground zero. I think there are some limited services we find, and that's probably due to crowding. It's probably due to time wait. I think there's a high degree of medical needs within the population that we serve. They've experienced a long time without medical care, and so it's as a residential provider providing substance use, cocaine, and detox, we obviously have what we prioritize. However, the medical neglect that they've experienced is really way up there. So it's hard, we really can't ignore that because it's very prevalent. And then I think there's also some stigma. We have met with some stigma with our specific clientele, and in the short time that I've been a part of this organization, I've even had some individuals reference clogging up clinics and clogging up ERs. But we're really dealing with a clientele that has gone years without medical attention, and they're not in a great state because when you come into residential treatment, obviously there's a process of decompensation that should occur. They should start feeling differently. They should start being exposed to stress, anxiety, and other things internally because that's part of the process. So you're not dealing with the most, in the situation of readiness a lot of times. And so I think our challenge in this process, being in a very early stage, is we have to do a better job of developing relationships with individuals. We have to do a better job of playing in the sandbox with individuals. And we have to then start that relational process outside of ourselves. We do have on-site providers. We do provide, then every day we have nurse practitioners in our building that we're in contract with providing consultation. A lot of times it's when the medical needs exceed
provide short-term residential services exclusively?
No, well, we have some up to 6 months length of stay.
6 months, okay.
They're not the Medicaid population.
Okay, all right. Yeah, so I've been saying to someone else that this sort of idea about integrating wasn't created with those kinds of organizations in mind, and so we're kind of squeezing you into a round hole, and so that's going to. I don't mind telling you, we didn't think of that, or I didn't think of that, and we're going to, have to give some thought to how this process can be useful to you all, or how you can not be burdened too much by it is another way of saying the same thing. But I think that with an SUD population, of course, the big thing is kind of neglected acute illness. So.
So question, you have NPs, are they psych NPs, are they family practice NPs? What are they, employees of yours or of a partner organization?
It's a partner organization, and in that partner there are a variety of different types of
Okay. So we've seen some nice, I'm always interested in, like, if I know of something somebody else is doing that you might want to think about doing, I'll share that with you. One of the teams we're working with elsewhere has a primary care, an internist and a psychiatrist that's assigned to their NP teams. And frankly, what it does is they can bring back, then they go back to that more experienced provider for advice and consultation, and they can bring it forward. You're nodding your head. So, I mean, that's something you might think about talking to your partner agency about. It's sort of, it could be a weekly case review of patients of yours, for example. There's lots of ways you could set that up. So anyway, that's just one thought to give that a little more structure, because I know nurse practitioners, they're great, they get asked to do a lot, but sometimes they can really benefit from, as any provider can, from having that wider team to talk something through with. So just an idea. Where to next?
Kate, we'll go with IFD and Kate over here.
Oh, there, Kate.
Thank you. Oh, we've got more Kates? That's right. Kate with IFD.
Okay, hello. So our agency here in Spokane, we're a statewide agency, but our Spokane office is what we're participating in this project. We do the WISE program, so we have it's an intensive wraparound mental health program for children. So it's very like a niche program, kind of a specialized program. So there's WISE, and also we have home builders. So in-home services for youth with mental health issues. Two different programs that are that we would look at to involve in this project. So, some of the things that we think we've completed pretty well so far are the involvement of our leadership in the agency. Our program director is on the Zoom thing, so she's listening in. So she and I worked a lot on this plan, and now we have our social work intern to help us implement some of the things. So we have that really going for us. Our agency's supportive. And also, I feel like we have another 5. Where did that go? Oh, we do have another 5. Yeah. That we've identified the whole person care champion. That's me.
That's right. Congratulations, yeah.
That became abundantly clear today. No, I'm just kidding. I knew that all along. But, and then the thing that we sort of look at, that we have the 0 is that we feel like we haven't even started, was putting a plan in place to sustain what we put in place over time. And I liked what you said over there about like looking ahead with the big picture, like this is all sort of driving us to that value-based contracting and the sustainability for the future. So that's something our agency and our team will have to work on in this long-term planning. So one thing that's just really interesting is with our 2 programs, we thought our pilot would be the WISE program of the 2.
And I think that's a great idea. Somebody else in the room has a similar arrangement. And I think a WISE program
is 3/4 of the way there already.
Right.
You know, it's a team-based, wrap-around, you know, close monitoring of a whole bunch of different kinds of needs, which could, all you have to do is ramp up the medical end of that a little bit, and then you're coordinating, you know, that aspect of their care. I think that people who've been doing that kind of work, or if anybody's doing a sort of community treatment, I mean, it's 3/4 of the way there. And so you've been doing this. You've been doing integrating without knowing it. So congratulations.
Nice to know. Yeah.
It's like, you know, it's like the person who was informed that they've been speaking prose their whole life and they didn't even know it. Kinda like that. Yeah, so I think that's great. That's a huge head start.
Good. Well, let's pass it to Rick. Rick with Children's Home Society. Great, thank you.
So we're pretty much on board with everything, but again, we are looking at the end, the MCOs. What are they going to be requiring? So, and you know, I do a giant eye roll with that because, you know, bottom line is taking care of our population, but I also got, you know, 400 employees that I have to keep employed. So somewhere in there, there's that balance. So, you know, the big statewide leadership team, they're on board with it. They love it. They, you know, but kind of the show me the money thing. So, you know, we love the navigators and all that kind of stuff, but getting the MCOs to necessarily all play on the same sandbox is virtually impossible. And I mean, I have weekly meetings with all of them and all of the big wigs there, and we can't even get them to use the same forms, let alone agree on, you know,
What they're going to pay for.
anything.
Yeah.
Yeah. So, you know, we can come up with this pie in the sky great thing that's going to be the ultimate service for our population. And then that last one, how's it going to be sustainable? You know, other than going out for private funding, which we do, but there's so much of it.
Yeah, and I think, and I think that pie in the sky is probably, you probably don't want to invest enough to have pie in the sky. You probably want to invest enough to have some chops at doing some of this, at getting some experience and getting your team and your center acculturated to this being part of the work without overcommitting to having something expensive and elaborate when you're going to have to shift gears a little bit when we finally find out what's going to be paid for. So yeah, so I mean, you've heard us say this a handful of times already. Don't go too big. Apologies to Catholic Charities, but yeah, you know, and just practice. This is practice in some ways.
We're starting to run a little long, but could you just say quickly, do you have a thought about what your pilot site or program might be while you're sorting out the challenges?
In northeastern Washington.
Yeah, here.
Outpatient. So it's, you know, I do kind of take it, you know, with
right.
our long-term care people and the inpatient.
Okay.
You know, I think that is part of our thing. You know, what do we do when you know, we have the chart flow, and when they blow out of outpatient, they need the inpatient
right.
around and all that. So I think it's good to have them in on the table with us, but it's all going to be around the outpatient, working with our local providers and primary care people.
Okay. Right.
You can pass right or left. All right, so day breaks.
So, Dale, we had, I mean, verbatim the exact conversation, because we're also primarily residential. So we had this big idea of tracking our clients and we serve under 18. You know, definitely make sure they're getting the services, because that's our biggest pitfall is once they lose that care. You know, and I think that's a different conversation with the MCOs about extending funding for longer term care. So what I realized and what our team's realizing is we were going way too big and getting focused on the pilot program. Our residential treatment already does a lot of this. We have a medical director, we do a lot of data collection, we have an ENT, we do a lot of that in inpatient, but it's also, you know, tightening up those with data collection and then really focusing on our WISE team, which is already out in the community and provides that longer term care, and really bringing the primary care aspects into our mental health and behavioral care that we already provide. So that's going to be our focus.
Okay. So Kate, throw it across the table at David.
So I've got 5 different hospital systems in 3 different counties, and we've done a great deal of this because there's support across the board. Everybody says we're in. And where we fall apart is number 9. So please take us to number 9. Put clinicians in mental clinics, and we may as well be playing in a separate sandbox with it. It's parallel play. It's 7, 8, and 9. And 9, I think, is really, what is the workflow? How are we really going to do this? So that I don't have a clinician sitting in office twiddling their thumb, and the doctor's going, where's behavioral health? We need the workflows.
Yeah, I completely agree. We'll talk, we're going to hone in. The process today will be kind of increasingly coning in from the...
And last month, we really hit number 8, and that was great. It was, the registry and track, that was fantastic, and that gave me a lot of ideas for where we need to go. So now take me to number 9.
You know, in the center I ran, we were like integration, 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 all the time, all the time, all the time. And then we brought in primary care, and they were they were down the hallway from like the psychiatric clinic, down the hallway, but you had to turn a corner. You know, the corner of death, and no one could ever go around that corner. And I would say, come on, you guys, come meet the primary care docs. They're awesome. They're like, no, light. You know, and you think, I've got it up, everybody's here, they use the same EMR, they're seeing the same patients, it's seamless. And so you'll never go broke, you know, overestimating the reluctance of people to actually integrate. So.
All right, we got one last champion here, and so Spark.
So for us, we're kind of at a 3. We're doing some of the stuff. It's already things that we've been doing, but it's getting it defined and having those workflows in place and identifying the staff members that are in charge of it or overseeing and like the champion. So we identified the champion. She just got voluntold. She's not here.
That's right.
Yeah. But, you know, having more of those working relationships with the primary care doctors rather than, I was someone over there that said, we get an ROI for their physician and we get their BMI and that's all we do. It's kind of what we do at this point. So how do we develop those working relationships and keep those communications open so that we're treating the whole person?
You're
So, that was fun. I enjoyed that. Question?
Can I talk about the bridge between behavioral health and medical? What they were talking about. So one thing that we did at Lake Roosevelt was with our we integrated behavioral health. So we started behavioral health. We had medical for years, and we wanted to start a behavioral health program. And so what we did, and we took this from a presentation that providers did from Alaska. And so we went to a meeting and they presented it. So what they did was, I'll just say what we did at Lake Roosevelt, is we hired behavioral health, kind of a crisis coordinator kind of a person. And then we had our behavioral health who actually did assessment. So I don't know if the rule is still the same now with the rules that changed in July, but so we had a person, my name's Allie, I came in, I presented, I have, I know everything, but I'm also about to lose my home, right? And I have some crisis that's going on. So doctors don't like to deal with, they don't have as much, they like to fix you, right? And the mental health crisis stuff is kind of like, I do the best I can kind of thing. But the way we bridged it was we provided that crisis person. And so we had a mental health, so I had my doctor came in and I can deal with your, whatever issue. And for your crisis, I'll bring in this mental health person. So the mental health person would come in, and it really helped our providers a lot because they could kind of, deal with what they were dealing with in their box, and then someone else could help with the crises. And that mental health specialist was able to see that person, I think up to 5 times before they actually had to have an assessment with a mental health professional. So sometimes they could deal with the crisis in just 2 or 3 visits, and sometimes of you, but sometimes you're waiting 2 weeks for an assessment, right? It cut down on our assessment time, so we were able to deal with crises, and sometimes people don't show up. You get 50% no-show rates because they're done with their crisis by the time they get an assessment, right? And so that person was just like the lifeline for us, and our providers just loved that, crisis person that could come in and help. I don't know if that helps anybody else, but it really worked for us.
Well, I think that's a great example of what we call stepped care. And so, what we used to do in the bad old days is someone would come into the mental health center and you would do the 17-page, 5-hour assessment, and they'd say, "Oh, I meant to go to the donut shop next door," or they just wouldn't come back. They'd say, "Thanks very much." And what's the average number of contacts in a mental health service? It's like 2, 3, something like that. And that's okay. And we used to think of it like you have to evaluate everybody comprehensively, and then you know what to do. And in fact, lots of people need a couple of warm touches, and then lots don't. And then you do the next thing. So that's a fantastic example of how well that can work. So that's So again, I didn't know we were going to be talking about this, but we've been urging you to go small. For those of you who can't see, the caption is, "My New Year's resolution is to lose 38,000 pounds." So don't overreach, that's all I'm saying. Okay, speaking of 38,000 pounds, it's time for lunch.
So half hour-ish, about 11:45, we'll reconvene, and I think then we're going to solve David's number 9 this afternoon. So.
We're going to start to solve Dave's number.
We'll start to talk about Dave's number 9.
Let's see, Sumitra right there has a badge.
Groups of like.
At this point, I'm just throwing out ideas. I'm looking for smaller groups that have common issues that we could work with via Zoom, or that we would have another
You're not
consultant
talking
that
about
could
like
work.
after
Yeah.
lunch, you're talking about
No, I'm not
down
talking
the
about
road.
after lunch.
Oh,
I'm
okay.
talking like, what does the rest of the year look like to help everybody get on the right path?
Okay.
Yeah, I'm not. No, I'm
Oh, okay.
definitely not talking after lunch. I'm more trying to think longer term. How do you get into
How can you efficiently
more of
deal
an
with
action,
different kinds of
action
You,
stage?
so in
Yeah.
Spokane, you have 7 organizations who do SUD inpatient/residential.
Yeah.
So that 7 includes adult and youth.
And by the way, you are the only ACH that are like, because of your big tent, this is the first set of providers like that that we're working with. So
good.
Unfortunately, you are our guinea pig.
You know what? I don't
Many
care.
people have backburnered them, frankly. Many have just backburnered that group.
No, they're alive and well and kicking right here.
Yeah.
No,
that's true. Yeah.
Yeah, we've got 2 school-based.
You know what? The school-based, I have 8 years of experience in school-based. I ran the mental health center, school-based mental services for Seattle, King County for a while. So anyway, I actually think they're going to have to decide what they want to do, but they need to look at some models for managed care models for charging for their
Spokane
services.
Public Schools is going to be in your LAN.
Yeah, right.
And they told me, just between you and I, they're on the cusp of a grant with Kaiser to open up a primary care in our most disadvantaged high school in Spokane. So we have got our fingers crossed.
Okay, so Kaiser sponsors numerous high-risk school-based health centers over in King County. So that's exactly where they ought to go. That's great. Yeah. That's wonderful.
So we're just waiting to hear.
That's perfect. And Paul is the practice coach for the school-based health centers in King County. So just to connect all the dots. We have a licensed social worker that spent many years in a high school, and he's been doing the TA for them in the last year.
So I think
so we have a good set.
Is going to be
Yeah.
top notch.
Yeah.
Yeah.
So, well, that's great. And Kaiser has traditionally liked to sponsor school-based health centers where in sort of their market areas as well. So they probably manage 3 or 4 of them over in King.
Wow.
Yeah, this is a sideline, but they do it.
Yeah.
And we have several large QHCs in the state that also add school-based health centers to their scope.
Okay.
So that would be something that Chaz or somebody else might. Chaz seems like they got so much going on right now.
Well,
but they might be interested in that, especially if Kaiser starts one, then they'll want to too. Yeah.
Public schools. So the grant they submitted or the application was with Chaz. So they would be partnering.
Okay, great.
It would be a partnership.
All right.
Yeah.
That's great. Okay. Well, they don't have to reinvent any wheels on that if they don't want to. They're pretty typically NP plus a mental health clinician staffed, and that is it. Yeah. So cool. All right.
And you guys are going to solve Dr. Nielsen's problem number 9 this afternoon.
No, but we're going to start. It freaked me out when you said solve it. Yes. Well, okay. All right. It's okay. We'll get there. We'll get started on it.
Are you going to half solve? Are you going to half it?
Well, here's what they're up against here is so many of them have multiple small primary care partners too, or in the rurals at least too. And, they're going to have somebody who really drives that workflow development and everybody can agree owns it. And so we're really going to talk process about how to go home and
do that.
Figure that out.
Do that.
Yeah.
Because he's in all the rurals. So
he'll have to do that.
Yeah.
So.
Oh, he'll do that.
Yeah.
Okay.
What's his background?
Oh, he's a PhD. Do I need to say more?
Okay. Is he a clinician? Is he a psychologist or? Okay. I'm going to go find out.
He's a character.
He's a character. Okay. All right.
So.
Well, characters are sometimes good if they bring a little sense of humor to workflow because it requires that, I think.
Yeah.
So. All right, we made through. Good morning.
That's good.
And do you guys need to do Zoom do we need to do a separate work group this afternoon, or can they watch and then they can do it within their own?
So we're going to go.
I think they can watch, and I can check with Hadley, but I don't think it was that useful for me to be up there.
Okay.
Yeah.
All right.
Yeah.
Okay, so we'll
If
just-
she feels otherwise, or they're different people,
Okay.
happy
No, we're
to.
fine. We'll
But
just do
yeah.
it. They can watch and do it.
Yeah.
Okay.
Okay. All right. Okay. Oh my.
Chicken and salad. Yum.
I don't know where that goes.
Oh, that's where the plates are. You're hiding them.
Oh, I'm sorry.
It's okay.
I tend to do things like
Yeah,
that.
tisk tisk.
Can't take me anywhere.
Tisk tisk. Yeah.
After a while, you get somebody in that money for 4 years. And that's the default. That's the default result.
So Ann,
Yeah.
so for our remote folks, if they have a question, they will just type in. And
Yeah,
so
that's how
Sarah
they're
will
working.
raise
Oh,
her hand
perfect.
and- yep.
That'll
So
be
you're good.
perfect.
Okay.
Because that's really the only way they were able to communicate anyway. And
All right.
their every question while I was there was, we can't pay for this, we can't pay for this. So it was interesting, but yeah, here we go. found my stuff all over the place. So Cherise, in King County, Kaiser sponsors its own SPHCs. I'm serious.
Yeah.
And a bunch of CHCs sponsor their own SPHCs, and they're all on the same team. So, but they have a tax levy,
Right.
Families and Education tax levy, that gives them minimal support.
Right.
They call them sponsors instead of contractors because they ante up a fair amount of their own resources to keep those things going.
Sure.
So anyway, so this is probably a Kaiser Foundation, okay. Which, hey, they may not want to do it more anywhere else, so if they want to support Chaz, that'd be great. They have plenty of money to spend right now. We know that about the new
rumor on the
Kaiser.
street,
Yep,
yeah.
that's what I'm hearing from
Yeah, shitty care, but lots of money. So.
well,
What should he care?
Kaiser over on this side of the state is, yeah, I don't know.
We call it. It used to be
They
called
don't-
group health, and everybody still refers to it as group death. But if they were at this particular high school, which is our absolute most poverty-stricken high school,
Yeah, no, that'd be
I
great.
think that'd be phenomenal.
Yeah.
Some and I think all of that Wyatt thing.
I told her I'm not twisting her arm on it.
Oh, I'm not.
You know, it doesn't take it too slow this point.
That's okay. I think if they decide not to, it might be really interesting to have Ponderay join. We could really maybe bring it a little bit different. Are you gonna yell at us? Be nice to these guys.
Really good. We just need your pack.
Oh.
Yours is. The full one.
Don't work very well? What do you mean?
No.
Can I switch the batteries out? So I'm going to go ahead and take it from you, and then I'm going to take it back over there and carry it, and then we'll bring it back to you guys. Thank you so much.
There you go.
No, they don't know it faster. There's just more signals and stuff.
Microphone check. Microphone check. Microphone check. Microphone check.
But at the same time, it feels better at the end of the day than going, you didn't do 10.5.4.1 of your contract. And
Sure.
All right, man.
Yeah. Right. Feels a little better.
Yeah. Yeah, exactly.
Awesome. Well, I'm glad. Yeah. Well, really nice to see you.
You too. I'm so glad you're still with them, and
Yeah.
we get to continue to move forward, right?
Yes, we do.
Yep. And I'll send that resume to you.
Okay, fantastic.
Super. You
Great.
betcha.
Thank you.
All right.
I think my piles are all mixed.
Huh?
How are you doing, dear?
Good.
I never get to see you.
Good, I know.
I know.
We have a date for the conference.
Excellent. I know.
Haley's great.
Yeah, she's
Yeah,
phenomenal.
she's been awesome to work with. We've had, she's amazing.
Good. Much better than me. I will, being frankly honest. Just being frankly honest.
Like, I don't have time.
I'm like, send Haley. She will do
Yeah,
something.
everyone who wants to, you know what I mean? Yeah.
No,
Yeah. She's been awesome. Yeah, I love working with
Very
her.
good.
I know, and this is great.
Yeah.
This is so informative. I was coming to say thank you.
Oh, yeah, you
just
guys, you
gonna-
gotta
I
talk
know.
to these guys.
I
They're
know.
wonderful.
Call her boss and we're gonna start calling ourselves.
You were amazing.
You see, you came for lunch.
You put us on track.
Oh, wonderful.
I'm gonna get there before lunch. I'll only bill you for 8.
Yeah, thank you.
You know, we just all chuckle because
Yeah. No,
everybody in the room, they're like, oh,
and we
dates her
definitely
for
want to
lunch.
do a DA
Okay.
with you guys.
I had
At some point.
Send an email
Oh
to
my
Sharice.
gosh.
We
Why?
were thinking, yeah, I was actually brainstorming in the
Yeah.
longer haul, trying to break this big group into smaller
We're sorry
groups
that it's the worst
that have more
February in history.
commonality.
Surely that's not making you
anybody
down,
with
and
wives,
school
anybody that's
stressors and
residential,
parents who suck, and
getting
yeah, don't get
Yeah,
to
that smaller group rather than
You'll grow out of it.
this big.
Live long enough, you'll grow out.
Yeah, exactly.
That's kind of where the real action's gonna be.
Pretty good, pretty good, pretty good.
Yeah, oh, that's great. Thank you for the feedback.
So far, working on
Are we behaving?
like actual
Phenomenally well.
Serious.
Yes.
like how long
Yeah.
has this been in place
Yeah.
of actually getting that information?
Well, we didn't, I mean, Medicaid, or I guess it would be HCA.
Yeah.
They can report to me.
Yeah, we'll see what they have to
I was,
say.
it's at least 5-6 years.
Yeah, that's what I
Is the early planning for this, and they've got us, at first they got a big planning grant from the feds, and then they got another grant, and then they had to go through, you have to go through all these approval processes.
Yeah, I
with
do
CMS
remember
to
it.
do it. Yeah.
Do I know who?
So it's been a long while, and
I don't know.
I've been working
don't
off
know.
and on. I used to work at a community health center, and I started working with the AIM Center in 2015 to move things along on this front, and we just dragged John on board, and he became available in 3 years.
I'd throw them in the recycle and see what happens.
So I
I mean,
did
if they are, that's great, and if not, they can throw them away.
Yeah.
Okay.
He started it with a big grant,
Yeah.
though, and you guys don't have the luxury of a
No.
grant to
No.
learn on.
But I did have to continue to do it without a grant.
That's
Yeah,
right,
so
right.
You had to make it sustainable, which was I think because we do a lot of it. I mean, that's the thing. If even we
Right.
have NYs, like you have a care coordinator.
Right.
So it's just putting in place for them to focus on also looking at that primary care. That's if I'm mistaken. But, yeah.
So I don't know that much about WISE, but I was going to, like, one of the things we've been trying to do with, and another kind of care coordinator navigator role is we're trying to create a very structured
doing okay?
pathway.
Yeah. Oh yeah.
Yeah, doing good? Oh, good. You
People
jump in when,
can-
oh, perfect,
Not
okay.
knowing who you have in those roles
Yep.
in WISE,
Yeah.
feeling like one where we can kind of tailor it to incorporate
Can I ask how Roxy's doing?
more of the whole person part of this that you're, that's one thing we're working on.
Yeah, no, that'd
Yeah.
be great. That's
Yeah.
Give her a little squeeze.
Yeah.
our wise we
Right.
have one, so she made
Right.
sure that we got it, which has been great.
Right.
Yeah. Yeah, sorry.
So we get you out, but we appreciate the feedback. It's really, yeah. So hard to know. So it's so nice when people say, actually, you said something that helped. Yeah. Oh, wait, I can go with.
Okay, so
We're going to be out of here early.
not me.
Oh, dang, I'm sorry. Oh, we get March off.
Huh?
Get March off, and then maybe we can turn this whole thing into quarterly. That's my goal. Yeah.
Okay, so you're going to do.
I'll do the tee up for this. I mean, and I'm not disappearing again because there's nobody on the line who has a clue what's going on.
Okay.
So I'm going to hold up. I'm going to invite Lisa up if she gets back. I hope she didn't leave. To talk a little bit about Chas and Lutheran.
Okay.
And oh, she's not here anymore. Did she move? All right. Well, we'll do that if we can. And then, John, I was really going to kind of say, I mean, this is just an example of something we've used locally. And then I was going to basically say what's
We're going to have them do them here?
yeah,
Yeah,
we
right.
can have them look at them here. Ah, this isn't moving. Do it at this. Oh, okay. Okay. So did we lose Lisa?
Yes, we did lose.
Oh, okay, all right.
Well, you get to talk.
I know, I just thought it would be nice to have somebody. She does a good cheerleader. She's at good cheerleading.
Yeah. Yeah. And you still, and so you're our guinea pigs Ponderay, you're going to go through the workflow
and we're going to point them on workflow when we get to work. Yeah. We'll erase that. Yeah.
And you're going to solve all the world's problems.
No, we're not.
Damn it. We're so close.
You just up my anxiety level, Reese. I already told you. Sarah, I was pointing out that because you guys have you're inclusive of today. All right, we'll get started. So really what we're going to do, our goal today is primarily to give you some tools to take back home that you can use with your teams and with your partners. So we're going to be bringing forward a couple of more tools, and then we'll wind up talking a lot about workflow. I keep telling Charisse, stop over-promising what we can do today. Because really what we can do today is give you some tools, some things to think about, maybe a few aha moments if we're lucky. I know we've had a few of those. But the hard work is when you go back home to your agency and have to work on that staff buy-in, et cetera, and planning. So, wrong way. So this is just a reminder slide. Those of you who are here in January or looked at about the first principle of all this work for whole person care is around, this is team-based. This is about creating a good patient experience, patient-centered, good patient experience. So in this particular slide, you see I made this a whole lot bigger because a lot of the focus for today is talking about those other team members who might not be licensed clinicians, often they aren't, but they're navigators, community health workers, pharmacists, et cetera, whatever, case manager, medical assistant, right? This is about thinking about everybody's role in a team flow, okay? And, all right. So we have, before we get in to the tools, well, first of all, I'm not sure if Lisa can join us by phone or not. Are we going to call her? Or I'm seeing no, not going to worry. That's okay. So one of the tools is pull out off your table. This is the one that has X's in it. Team Building Roles Assignment Worksheet. Example, it says at the top, collaborative care tasks for BHA and primary care team. So I brought this specifically because this is the tool that Lutheran and Chaz found on our website. It's part of our implementation guide on the AIMS website, to try to figure out how they were going to structure their shared team in their new the new geriatric clinic they're working on. So, and unfortunately, Lisa couldn't stay to give us some thoughts about how that process went. She wasn't too directly involved. But so I'm going to tell you, because I was involved actually back in November when they contacted me and said, can you give us some help? We're trying to figure this out. Can you give us some advice, right? And they had found this and already on their own had kind of gone through this with their own planning group from both agencies to figure out who was going to do what. Now, where they are right now is Lutheran still hiring. What they call, on this sheet, is called the BH Care Manager. They're hiring for a licensed social worker in that role. I don't know that that's what they're going to call them. They might just call them BH specialist, something else. I'm not too worried about the title, but that's the Lutheran part of this. And then there was also a lot of decisions went into, do we need a nurse, do we need a pharmacist, et cetera, et cetera. So, but this is the tool they went through to try to figure out, okay, who are we going to hire, who are we can assign existing staff, et cetera. So they found it useful. So I think this is one of those things you might take back, and if you're having, remember I was asking about Annabelle, who your partnership meetings were and how was that going. One of the things that we've seen partnerships get stuck on is getting past the senior leaders talking to each other about, yeah, we want to do this, right? How do you get into the weeds of what will the team actually look like? So here's one tool, and I'm going to share another one as well, for try to really get into those weeds about how is this going to happen. Might be a different set of people at the table, and maybe not so much the leaders, but maybe the team that's assigned to it. So what happened with Lutheran and Chaz is they went ahead and they hired an RN, and they assigned her all the medical tasks, and they assigned everything in behavioral health to the BH Care Manager. Thoughts on that? Any thoughts on that? Questions, or make sense to you all, or whatnot? Well, one of the things I suggested was you could actually have that nurse do a whole lot more than you're asking of her right now. There are nurses all over the country that do good depression care. And sometimes they do that along with managing diabetes and hypertension and everything else. And that means your patients only have to talk to one care manager instead of two. The nurse doesn't have to, oh, your PHQ-9 is 15, so you have to go talk to Joe down the hall. And when Joe sees that the blood sugar is way out of control, oh, you know. So trying to eliminate those trade-offs between all those care managers and other people patients interface with is one thing that you want to think about. So the outcome of that, when I asked them, I suggested think about training your nurse to do a little bit more of the basics of good like behavioral activation for straightforward depression in the geriatric population. We're not asking her to take on the patients with psychosis or the bipolar. We're just asking her to take care of some of those older patients that have many medical comorbidities and maybe some anxiety and depression as well, right?
Lisa's on the phone. I'm going to try to unmute her.
Okay, great. So Lisa, thanks for joining us. I've kind of walked them through my part of the process, but if you can give us sort of a high level about how Lutheran went about developing the partnership and all of that, and maybe people can ask you questions.
Yeah, thank you. And I'm sorry I had to leave out, but we are super excited about this partnership. It is a geriatric clinic serving 60 and plus. And I think some people had talked about some great things about really what does that look like when it comes down to those workflows and how that interchanging happens. So we are still, as you mentioned, looking to hire, so we're not at that stage yet, but having support from leadership and those meetings and that collaboration, and then really giving us that time to look through like policies and procedures, since it's an employee of ours and in the CHAZ and their employees, and how does that all work together? And so giving us time to have those discussions to kind of flesh through what that looks like has been just a real good benefit to just enhancing that partnership and strength and collaboration.
So Lisa, anybody got questions for Lisa? I've got one I'm going to tee up. So first question's for me, Anne. How did that partnership start? Who talked to who first?
That I don't know. As I mentioned when I was there, I've been in this role for just about 2.5 months, and so that had been happening. Tiffany Kelly, who's our clinical program director, has really been the champion and really working with the Child's Clinic and the staff there to kind of flesh through a lot of those processes and stuff. So she's really been a champion, and so we're excited about what that actually is going to look like for us. But I don't know the answer to that question. I'm sorry.
Okay, sorry to put you on the spot with one you don't know. Was that clinic, is that a brand new clinic, or was it open before this partnership existed?
So it is the old Christ clinic, and it's now the North Central Clinic. And so CHAZ,
Okay.
It is the partnership between CHAZ and Lutheran, specifically for that population.
Okay. Does anyone know who ran it when it was Christ Clinic? Sharice is coming up to give us a little background.
For some weird reason, I actually might have a little bit of information here. So Christ Clinic was going out of quote-unquote business. They were a nonprofit, and they were looking for a like-minded organization to, be interested in that clinic and the property. And so for you, Lisa, they actually approached Lutheran, and Lutheran then approached CHAZ.
Oh, there we know.
Right? The random person in the back of the room knows this much sometimes. But so that's the history on how that partnership came to be.
Thank you.
Great, thanks. No, I was reading that between the lines when I worked with them, well, anyway, it's just a nice example, and it's local, and it's opened its doors in December. So, CHAZ and Lutheran did their own work on this. They had several meetings. They pulled together the team. They went through and created their version of this. This doesn't exactly reflect theirs. Theirs was actually much longer. But this gives you a flavor. And we will post a worksheet like this on the BHT website if you want to use something like this. Then they called us, and this was before we were working with BHT, and I quite literally spent like 1 hour on the phone with the team, reviewing the spreadsheet and trying to poke holes in it. Have you thought about this? Have you thought about that? That was where I said, wait a minute, why don't you train that nurse for depression care at least, because there's no reason to use your clinician, your licensed clinician, for every moderate or low-level depression PHQ-9 score until you know they might need more intensive services and working with a licensed clinician. Also, as a sustainability strategy for CHAZ and Lutheran, or anybody else who has a behavioral health clinician nurse team, you can bill the nurse time on the collaborative care codes. That's about the only thing in Washington State Medicaid that where you can bill for nursing time in a behavioral health provider role. So that's one to have on your radar for longer term sustainability, is you can use nurses in that role. And you often do a better job with, yeah?
So the collaborative care codes, just for these, because I'm sure these folks are like, what is that? How do we learn about that? And so later, probably this summer or fall, we will be looking at having some specific training around the collaborative care billing and codes.
Right, and we have until then, because I heard so much concern about planning ahead for sustainability, I wanted to plant that seed now, because we are seeing others around the state recognizing, okay, I can do better billing my licensed behavioral health provider in fee-for-service world still, and if I do use a nurse in this behavioral health team, this is the only way I can try to pay for that nursing time. We have a 2-page cheat sheet on our website, and we're happy to help anybody who wants to hear about it sooner than later get up to speed on what that would mean. Okay. All right. Question?
Yeah, you talked about nurses screening for depression. Do the codes limit them to depression, or can it be ADHD, can it be anxiety, can it be, or is the task limited as screening only?
It is a treatment role for the RN, yeah, and it could be ADHD and others. But you're taking me down a rabbit hole that probably applies mostly to schools. But I'm happy to talk to you about that. So.
It's a good rabbit hole.
No, it's good. It's a good idea. You know, there's actually, we're going to be training, not to get too far off track, but we're training our first pediatric cohort of 6 practices from 3 different ACHs. We're going to be doing that down in Olympia in 2 weeks. We're supposed to do it, and then it snowed really hard. So we're going to have that. So if there's interest, we'll have that curriculum and all of those ideas to share. Okay. John, do you want to talk about the other tool? So this is one tool. And we've also got the team building workshop. We have too many tools named.
Too many tools.
Team, this and that.
Okay, yeah. So these are somewhat similar, and they're really, one is derived from the other. One has really got a primary care, behavioral health and primary care emphasis, and the other has got really what more of us are here talking about today, which is the primary care and behavioral health outcomes. And so really the idea here is that this is kind of one tick farther in terms of you say, well, we're going to screen, or we're going to educate, or we're going to track, and so this is one tick farther in. Who's going to do it? What's that going to look like? And then if we have time, we'll do one tick farther than that even, which would be to say, you know, to look at what an actual workflow looks like. So.
So I think of this. I think of this sheet, the one that's shaded in. You see there's a list there of basically good health education, health monitoring tasks. If you're building your own capacity, this is a tool. I was thinking, this is a nice tool for nurses or NPs. You know, everybody in healthcare increasingly uses a checklist approach. The airlines use it to keep those planes in the air, and surgeons use it to make sure they don't forget something critical in surgery. So we're a big fan of these kinds of task lists, but I like this because if it's your partner or if it's you, it's sort of like, what are all the things you should be thinking about for someone who, as someone said very nicely earlier, hasn't really been engaged in primary care for a long time, has a lot of unmet need potentially for good medical care and hasn't received it for some time. Okay. So these are a couple of tools. Does anybody else have some other tools they've used similarly or other things like this? Anything else? I mean, this is obviously not the only way to do it. It's just kind of the things in our toolbox for you to take back. You can adapt. You can change up. We'll post a spreadsheet. You can change the spreadsheet in any way you want, but to just give you an idea of how to kind of do that nuts and bolts planning with a clinical partnership or a clinical team. Okay? So we're going to give you a little time to just think about how you might use one or both of these tools with a partner or an agency. We'll do a very quick, maybe just a volunteer report out rather than hitting everybody. But you know, if you have any ideas about how you might take that tool home and get some good use out of it, either one, let's give you a little time to look at that, okay? You have a blank version of this that you could actually fill in if you've got your team here today to do it.
Like, for example, one of the questions has to do, you know, with particularly with who's doing a certain task. And I had talked with somebody earlier today, and they were kind of terrified that their clinical staff would fall apart if asked to do all these things. And the point of this is you're not asking everybody to do everything. That you're going to start, right. And at DLA you'll be volunteering people who aren't here to be doing most of these tasks. Okay, so it's like 8 after.
Okay. I bet they'll be done
10 minutes.
a quarter after, or a little. We'll see where they are in a quarter. Okay. All right, you got a whole team here. We expect a good, big report out from you guys. Yeah. I'm kidding. Well, you've already been working on it. Great.
Yeah, we're really not as dumb as you think we are.
I'm not suggesting that, but that looked like you got a lot going. That's great.
We're trying.
That's great.
Working on it. All right. So, identify and engage patients. Identify people who may need help. Okay. That's everybody we work with. So, who would need some help? What have you filled in there so far?
I just I don't have a paper. She hasn't typed it in.
Oh, you can't. It's not one you can enter into.
You know what? I think they probably posted just the PDF, but we can post ones that you can fill in. Yeah. We'll do that. We'll do that.
We can start. It's like, it's known. What do we need to do?
Currently homeless.
So just one thought on. I know you're in the middle of doing a couple of things, but like if you've got NPs coming over, you've got to make sure they're serving a very highly complex acute. A taskless approach, nurses do really well with that. You know, so we'd be happy to like have one of the nurses we work with, or nurses that work with some, you know, other. We've got several nurses on our consulting team that like have a lot of experience working with those with serious mental illness. So anyway, just a thought on how to further develop and make sure your partner is really keeping your priorities
some of our, we've been having a series of meetings with our providers.
Uh-huh.
And those gosh teams. You've been a part of those, I've been a part of those, you've not. Yeah, the other
I was not invited.
We like to talk about him behind his back. It's no fun face to face.
Yeah, they're like a niche.
We're trying to still develop the collaboration within that team. Because we don't feel, I don't feel at times they take the mental health need. I think there's times they make orders that put the clients at risk.
Right.
So yeah, they need to go to Chaz or they need to go to this clinic. They're not really in a position to leave the building at this moment. There's elevated risk, I'll say it that way, so I'm not exaggerating.
Okay.
There's elevated risk in leaving the building. And so now we're sort of stuck between that tug of war between what's best for their mental health needs, behavioral needs, and what's best for their medical needs. And obviously the person taking the medical liability is going to side on the medical liability piece. And so do we take this person to the dental appointment even though they have the same dental problems? We're now addressing the dental issue while
What's
they're in
gosh?
treatment.
Right.
Because they're able to feel, because they're not on their,
Yeah.
they're not shooting up in an alley right now. So that
Right.
Oh, okay, good.
So those little complexities of where do we prioritize becomes a role in our collaboration.
Same with supported employment.
John would be the guy to get on the phone with, say, I don't know.
Is there any
and
part
I don't
of
know
the
what
organization
group
that
within
everybody
Chaz
comes
you're
in
working
contact
with.
with?
Is there a particular
Well,
Chaz
Chaz,
supervisor that you work
we don't
with?
have an agreement necessarily
Okay,
with Chaz.
right,
It's just
right.
the practitioners sometimes will pick.
The blessing and the curse.
Sometimes we'll pick
Lack of
sometimes
centralization.
we'll pick an urgent care.
So you're
So
really,
in one of my old shops, what we did is everybody,
You've got
the
to
way we
develop
kind
that
of
relationship.
made
Okay, got it.
contact with everybody, we
I got
rubbed
it,
up against them
okay.
eventually, is they all
Well,
came through
when you
psychiatry,
get
they
to
came through
that-
the psychiatric clinic. And they go out,
Look,
anytime,
when you
then
get
we'd say, okay.
when you're vetting some of that,
They had to come through there, and
I'm
they couldn't
sure
get
like
away
John could
without
join
us
you on a call
saying,
with them to make sure
take the
everybody
screen,
fully
stand on the
understands what you're
scale.
asking them to sign on
But you guys
for,
don't have
frankly.
that. Is
He
there,
is a big
so
believer
the kind of, you
in
have housing,
that anybody trained in psychiatry should also be able to manage straightforward conditions like hypertension and diabetes. And really, so is the National Council. They put a white
again, you may
paper
have
out
to,
on
you may
that,
have to
so-
pick.
But
It may be
not every
smart to
NP
pick.
is going to feel
For the
comfortable in
purposes of
that
this.
reality. So yeah.
As far as hypertension, diabetes, what are some of the other more common issues? And we have seizure disorders, dental
Yeah,
issues.
a lot of dental issues.
I think we have to pick I don't think we have to pick a building. I think it has to be like either chronic illness.
Right.
We try not to admit them all sometimes.
Right. Yeah. You have do a wound care team instead.
You'd probably want to pick a high risk medical.
All right. Well, I'll leave you to be thinking it through. A lot of the
Chronic or
metrics
senior.
for Medicaid are around diabetes.
Chronic, that's really the.
For better,
that's really
I
the
realize
intent.
you've got people with a lot
That's
more
really the intent of this.
wound care,
It's the
other
care.
needs.
It's the care
But
of the
you're,
seriously
as
mentally
you
ill.
kind of get ready for
That's
those
what this is-
MCO
that's why this
contracts,
is
you're going to want
invented.
to probably
That's why
be able to
that's
speak
why
to good follow-up on
eventually
high blood
Medicaid is
sugar,
going to pay
blah,
for
blah,
it
blah,
because they
blah.
think that
So,
they've recognized this
yeah,
as a real
I know
thing.
that isn't
And you
solving
can
the
use
universe
this
for your patients,
kind of
but
infrastructure to do other
that's
things
a big
if you want.
emphasis
But
of
that's
those
not really,
contracts.
and
it's kind of
Right,
ironic,
right, and
frankly.
that's why-
I don't
and
know
that's
why
why
they
they're
picked
willing
on
to pay for it.
diabetes, because more people with serious mental illness die of cardiovascular disorders. Yeah, it's usually, and that's actually nationally
Yeah, and
drives more costs.
that's where the money is.
But
though.
our state in its
So they
risk
come
pick
in and they die in 6 days. and
Which
they
usually
cost
is happening along with
$437,000. That's what they don't want to happen.
So,
I mean, the conditions
Yeah.
that people wind up in our facility.
And so what'll happen? So what'll happen when you
activities
do
that
this
put people in our
successfully
facility are more likely
is that people will start going to see the primary care doc, and their outpatient costs
Yeah,
will go up
right.
for a year or so.
Yeah.
And then what'll happen later is that the big ticket ER,
Right. Right.
ICU costs
Right.
go down in the long haul.
Yeah.
Degree of medical neglect, self-induced.
Well, yeah, I mean, so Medicaid
Is
can
there
do
a
that.
health
They
care
can say,
for the
here
homeless
are these people you
grantee
saw,
in
here's
this
people who had an event with
region?
you,
Okay,
here's what they
I'm-
cost this year, here's what they
I'm-
cost this year, here's what they
I've-
cost this year.
I asked several people
That's
that
where
today,
that's where the
nobody's
data
sure. I'm
it
gonna
comes out of
look it up.
claims data. That's the only place you can get
It's
this.
a program to
Out of Medicaid claims data, yeah. That's really the only, and it's a good way. It's a good way of doing it.
But the Christ Clinic is
they're
the one
often
that just
chintzy
became
about
the new
sharing it.
Lutheran. So yeah. So
I don't know that much
that's
about
feeling
Washington.
like
I
a
know
gap
where I
to me.
come
That's a
from. They're
federal
chintzy about
ongoing grant that's available to
You're like,
do
well, wouldn't it be a good thing if we knew
medical
so we could
care
do something
for,
about it? Oh, well, maybe.
homeless and in transitional housing.
But I'm not listening. Blah blah blah
Yeah.
blah blah blah.
Yeah.
We got a group that,
Yeah.
and I noticed that.
Yeah, but in some states it has been possible. Missouri, for example.
Medical provider, the rest
So Missouri, where they did the big health home thing, they were able to get them to share claims data.
No, that is tough.
It takes a while. It's like a little bit
It's not like
geriatric
that many
by the time you
providers
get
are
it.
going to
but it's
want to
still-
embrace your
it's
very
still worth
tough to
having.
serve. Yeah.
Yeah, so I think I would
No,
pick,
no, it's really
pick a
tough.
spot for these purposes and get
All right,
your
I'm
chops
going to
on
keep
that.
moving
And
around,
and
but
what you'll
that
find out later,
really
what
is
you'll
like
find out 4 years from
a
now.
big tough one.
So what'll happen 2 years from now
So-
or whatever, a year from now, is that you'll be no longer under the BHT umbrella. You'll be getting paid by integrated Medicaid in some way to be named later, but I'm pretty sure that it's not going to be very stringent. So it's going to be kind of like pay to participate kind of stuff. Like do you submit metrics? Yes, no. And so there won't be any teeth in it for quite a while. So you don't have to. You can play with it and you can practice a little bit. You don't have to worry that if it's not big enough or if it's not successful enough that you're going to take a hit, because you won't. You won't. Not now and not next year. BHT is sending you people money. I don't know exactly. That's it. I mean, that's the intended mechanism through the Medicaid Transformation Project for you to have resources to skill up or infrastructure up to be eventually have some capacity to deal with value-based payment. So I don't know. I don't actually happen to know what BHT is paying you guys, but that's where. So it's like, I don't know. So it's like.
All right. Okay.
80, it's $100,000, something like that. I mean, that's the rough number.
What's
and
that
that's
say?
that's what that's for.
Child
That's
family
for.
team coordinator.
Okay. Okay.
And to pay for driving this meeting. That's the intention. Is that's what that money would go for. Yeah, I mean, if you can make additional deals with the MCOs, which they might do.
The roles don't fit, so we're changing.
I knew the roles wouldn't fit. We'll put it up as a spreadsheet so you can change up all the roles.
Yeah.
So,
Yeah.
but yeah.
I mean, it's like there's this question about how are you going to pay for this, and what's the rate, and not just how, but what's the rate going to be? And I cannot get an answer, not for love or money.
Care workflow for ADHD.
And we have this very close relationship over the decades with CHPW.
Anna Ratslip has been very involved in that. We actually managed to hire a social worker with great kids.
And so I think it's kind of.
She's also developing it, and we've been working with
It's rigged.
Some of the organizations like Virginia Mason that have huge ADHD practices, and they're already tracking the registry and stuff. So we're happy to
that's
share
always
that
true.
with
The
you.
question is, in a
there's
rigged
couple
world,
of
is there a place for you guys to
agencies
keep functioning?
over in this side of the state that are very interested in doing something with pediatrics. So we're hoping that after we get this
and from their
figured
point,
out
you
over
got to
with
remember, from their point of
Cascade
view,
Pacific, maybe
they
we'll bring it over here
sort of
and
believe,
also.
they kind of believe that doing this will actually save them money. They're not sure,
There's
but I can tell you what I
clear
do
about
know.
ADHD.
What I
The
do know is they're not
Vanderbilt,
sure if they believe it.
And we've interviewed
They're like, it could
probably
be.
10
There isn't
providers
a
with a lot
drop
of
dead
experience with the
comprehensive.
Vanderbilt, and they're all using it differently.
Example.
And it's a pain.
There's
It's
the
a
Missouri Health
complex
Homes,
tool
which was
with
very
multiple. Some like BM are using it for monitoring, others are not. So there's nothing
just in
clear
terms
about
of
it.
using this, this is how
In
you
all
start.
honesty.
This is kind of how you
And
start
the 9
thinking
is all
about,
you need on the
really like
for
who's
most
going to
kids
do this?
for
Is it going to be
12
your?
and up.
Is it going to be your central?
That's what Bob Hilt does.
Care coordinator person.
All right, we'll be fun.
And depending on the size of your organization or the number of people you decide you're going to be working with, just to give you a really rough rule of thumb, my program we had 700 people we were working intensively with. It was a big program, and we had 2 nurse.
Okay, how we doing?
About 4 case.
Everybody had enough time, I guess.
About 4 case managers devoted.
Anybody want more time?
And that was with a pretty sick, chronic SMI population.
A few minutes more?
Post grant,
Give you
we
2
had
minutes more.
1 nurse care manager and a couple case managers. And a lot of they're doing this stuff anyway, and you just say, and also do this, and also do this. So I don't know, like if you were going to be working with the populations you had kind of proposed, the chronic or the, how many people would that be?
We can get a spreadsheet. Rather, I think right now you've only got a
250, that's a
PDF
big-
to post.
Yeah.
And we can
Yeah.
send you this for a red sheet to post, and then they can
No, understood.
lay it.
That's 250. It's like 5, 15 unit buildings.
Right. Everybody's already changed all the names across the top.
Yeah. No, I think that would be a good idea. And then you'd see, and what you'd find is that's, and so you have to have people, you have to have somebody like keep track of the data and like, somebody's blood pressure's going to hell. Let's make sure they get hooked up. Somebody's sugar looks terrible. Let's make sure they that everything's in place for them to get better. But in the course of a month, you don't touch most of those people. You don't do anything with most of those people. You're just following. And in terms terms of like medical oversight of it, having to have, a lot of this is like, and anyone could look at the list and say, oh, that's a bad number, and you'd have like a drill for what happens if someone's labs come back bad, you hook up with their primary care provider or something, or you'd have some drill. In terms of what I'm trying to do now is save you money on staff. And maybe you need nursing input, but you don't need it all the time, constantly all the time. You could have somebody come in every couple of weeks and look at that.
Let's go ahead and do a little bit of sharing out. No, I can do it. I can do it, because then I'll be standing right next to the mic to use it. Right.
Just give them a nod.
Right, okay. All right, I can see John's heavy into workflow development back there. Okay, let's just kind of have everybody pull our, no, that's all right, it's okay. I'm thinking in the interest of time and everything, we're not going to do everybody, but we'd love to hear from everybody if you've got. I'm going to keep an eye towards time to make sure we get you out of here on time today. But would love to hear, like, which of these tools were useful? Any thoughts on how you might take them forward to your pilot programs or pilot sites? If you were in a team, enough of a team today that you can really say a little bit about your team composition. I saw a lot of people drawing lines through the titles at the top and putting their own names there, which is great. We're going to post this as a spreadsheet for you so you can go ahead and use it if you want that way. Any challenges, opportunities? Anybody got some words to say? I'm going to tee you up, Spark, because I saw you doing a lot of work. For the team that came in saying you didn't know what you wanted out of the day, you did a lot of work.
We're not ready.
Well, can I just show them that you've got, look at this. Look at this. They're not 100% ready, but they certainly made more than baby steps today. So do you want to say anything about what you did? No? Okay. I'll leave you alone. I'm sorry. Well, I just want to say good work, because if it's useful to you, that's what you got to do. Anybody else? I'm terrified now. I won't. I interrupted her train of thought, and she was getting work done. Jennifer, you all were having a conversation over here. Dave?
No, it's your turn. Kristen said you.
Well, we looked mostly at the team building roles assignment worksheet. We were one of those crossing off roles and talking about who could do what, and this is exciting for us, I think, because these are breaking down some of the workflows and tasks that you can have conversation about, which is paper is extremely helpful.
That's this one we're talking about, yeah.
So it just helped us. We had all sorts of ideas brewing over here as we were talking about it. So I don't know that I have any specifics, but I think it's heading us in a direction we've been looking for.
Great, good. Well, the spreadsheet we have, you can play around with it. It's got another whole tab that gets into the weeds even further. Some people find that useful. Some people say, no, I'd rather just go straight to my protocols and procedures than fill out the spreadsheet, which is a totally valid way to get things going. So you have 5 hospitals, right? And she's one of them, though. So how are you going to deal with 5 hospitals? Are they all going to have their own spreadsheet?
Yeah, I think it'll be different in each. It'll be 3 counties, 5 hospitals. It'll be different with each one of the partners. But what's nice here is that it gets much more specific, I think, than we've been about what exactly are we going to be doing and who's going to be doing what.
And he's pointing to this as being very specific and task-oriented. Great. Okay. Good. I'm just going to suggest if you get a really good workflow with Lincoln, then you don't have to start at 0 with the other 4.
Right.
And the more you standardize that, the less likely you are to drive your own staff crazy.
I don't have a problem
I'm gonna try my staff.
Oh, well, some people do. Did you have your hand up? Anything to say?
No, I was just agreeing that he was gonna drive us all crazy.
Oh, he is going to drive you all crazy. All right, well, then your job will be to rein him in. Okay, all right. Other thoughts? Annabelle?
Well, we were just thinking, this is also going to help inform the shared care plan and what's in the shared record.
And she's pointing to the specific task list. Yeah, great. Can you say more about the shared care plan?
Well, that's on the wish list.
Okay.
That's where we're hoping to go. And it will build in some accountability and hopefully reduce redundancy. So if I've got folks doing this, there's no reason for someone at the hospital or the clinic to do the same thing, especially if we have a shared record. Is that making sense? Yeah.
Okay, great. Anybody else find this one or the other more or less useful, or ideas about how you might take this back home and use it? Okay, I've been told to pick on you. I didn't do it.
We like this one. We really wrote the roles. But one of the things we did like is the fact that it asks questions that don't fit really well, but that broadened our thinking, because oftentimes you get stuck in the ruts and you just go down thinking one way. And as we tried to look at more integration and broadening out how we interact, it did some forced choicing, and then we'll have to write a few more questions. But that kind of was a nice problem.
Okay, good. And you can see how if you do this with, whether you're a big, complex, messy organization like a school district, or you're doing it with partnerships, how this one sort of helps you kind of negotiate the roles. And then this gets you into the weeds, of good whole person, incorporating all the medical concerns you have for your patient. So that's the idea. Anybody? I'm just going to walk through and see if anybody found anything useful or to say. No. Not quite there yet?
The same that everybody else said, pretty much. Yeah.
Okay,
yeah,
great.
They're useful and they're great.
Okay.
Yeah.
Well, they're only useful if you
See,
train them up. I know, I see. Great. And it also, I'm hoping it will, for those of you who's really your goal, I understand you got a real clear goal of we want to have that care coordinator. How are we going to pay for it, and what will their role be? Even if you just think of it in a limited way like that, you've still got to have those task lists and train everybody else what to expect of that care coordinator, right? Coordinators. Okay, all right. I think we're done with this part then. Anybody? Nope, I don't see anybody raising hands. So we'll move on. I keep going the wrong way. Workflows, which has been raised as a big consistent theme. But you understand that you can't figure out your workflow till you know who your team is, right? You can't, this is one of those, kind of have to take this in order. Identify the team, figure out the workflow for the team, right? Just to be clear on that. We have a number of resources here. Same idea here of bringing you tools to take home and use, and using what time we have with you today to talk about how to go about taking this back home and doing the hard work of testing and piloting workflows. So I'm just going to talk a little bit about that for a while. So let me move on to, first on this list is a toolkit for PHQ. I got to get a drink of water. And there, you should have a couple of copies on your table. And it'll be posted. Now, you are, for the most part, except for a couple of exceptions, behavioral health agencies. This is not a tool for day-to-day use for you. This is aimed at primary care. And I'm sorry to say we do not have a comparable tool for you right now. But I thought it would be useful for you to see this, because these are the kinds of things that your primary care partners, or if you're building capacity, are using. And the PHQ is one of those really important pieces of common language you have with primary care. PHQ-9 score is what primary care uses to assess symptoms, diagnose depression, and more they use the PHQ to assess symptoms across a wide range of diagnoses, bipolar, PTSD as well. So experience with the 9 right now, how you're using it in your world? Yeah?
Our psychiatric ARNP uses it to assess every kid that comes into our inclusion.
Great. And when we teach primary care to use the 9, we'll be training them to use the 9 at every visit. And starting it at every visit. So not just screening, but monitoring. Not just diagnosis, but monitoring. So when somebody makes a referral to you, you should ask what that 9 score is. This is also a metric that's going to be likely to loom in managed care contracts. So it already is, and the screening is. So I'm just going to walk through this very quickly. This is just the very basics. It's meant to be very introductory, because we wanted to put together something that people could use with their non-licensed staff, their front desk, and everybody who might touch the PHQ-9 score or be held responsible for making sure there's an accurate score entered in the EHR. So it's kind of like learning how to take a blood pressure test if you're a medical assistant. At the bottom of page 4, you'll notice that there's a source online for free PHQ-9 screeners in, 70 or 80 languages. And I'm always amazed that a lot of people don't realize that's out there. But phq9screeners.com, it's a site, it's sponsored by Pfizer, but it's free, and you can download the 9 in any language you might need. Lots of versions in Spanish, as well as the GAD-7. So a little resource there. Now, this next page, we put that together because the 9 is often administered, or at least recorded by somebody like the front desk or medical assistants. And we've often seen that be the weak link in good screening programs, where if they don't understand how important it is to get this right, and it's important that it be entered, and the primary care provider know if there's a positive answer on the suicide question, or if the score is high, so that they're informed of that before they go into the appointment. Those are things that sometimes people don't have good tools to train with, to train their medical assistants or their front desk staff with. So this is put together for that. We're going to be happy to put together something similar for you all if there's ever a need. I just don't quite know until we figure out what screeners are in use and where and so on. But I wanted to share it today because it kind of gives you an idea that you have to take very seriously your role of educating around using, developing screening workflows, et cetera, et cetera. So I thought I'd just share this with you today to give you an idea of some of the steps to go through, okay? Any questions? Was this useful? Anybody? Take it back home. I mean, we even put together a little FAQ, a frequently asked questions for a medical assistant who might get asked things that makes them uncomfortable, primary care. So that's the kind of training support you have to give to anybody who's using your screeners, touching your screeners, so for workflow. So this page 7 is about training, testing, making improvements in screening workflows. All of this really kind of cuts across whatever workflow you have to develop. And, you know, Sonia, we're going to put Sonia up here in a while to talk about workflows and development, right? Annabelle, they're looking at each other like, huh? Remember, we're going to tee you up for that a little bit. But we put together this toolkit for the rural health clinics. WSHA asked us for some help because many of the RHCs and CHCs actually have money at stake, pay for performance money at stake this year in screening for depression. So they're all working hard right now to get their screening scores, percentage of patients screened up if they weren't up already. So this was a tool for them. And it's also a pay-for-performance requirement screening in a number of with at least 2 health plans currently this year. So I don't know that it affects BHAs, but it's the kind of thing that might well come your way in the future. So Sonia, you want me to talk a little bit? I'll give you a chance to get your thoughts together. I also brought the confluence. Those of you who were here last time, I brought the hypertension workflow again. Because we actually handed this out in January, but we didn't really talk about it. We just kind of handed it out, I recall. So talked about it a little bit. So John, if you have, oh, here's where the whole person cares. Okay. If you want to talk more about this, because John developed this with Help Confluence and others developed theirs. The point I wanted to make was this is a very complex workflow, and this is the kind of things that you may not need to do out of the gates, but if you're talking whole person care, you've got to talk about a lot of things in that workflow. It's not just about controlling blood pressure. You'll see, look at the workflow and you'll see there's, the workflow goes 2 ways. 1, has a primary care provider. 2, does not have a primary care provider, right? So that in and of itself is a huge task and a workflow unto itself that didn't really get addressed on this page.
Right. So how many people here have actually ever flowed out a process in their clinic and actually used it? One. What happens when you do this? And it's an interesting first thing to do when you're going to do workflow is flow out something that actually you do now, something that actually works, a process that actually works. And what you find is that it's crushingly complicated. There's all kinds of decision points. There's all kinds of things that you do in places you get information. And you look at the whole thing and you're like, well, oh my God, how do I ever make it to lunchtime? It's just, and this is just like, how to unlock my door. And so when you look at a workflow like this, you say, oh, that looks pretty complicated, but it's really not. It's really a fairly simple process. So why do this? Well, I think one of the things that it does is it takes this and kind of drags you in one tick closer. So you not only have to say somebody's going to coordinate, you say what piece of paper is involved, who do they talk to, where does it get written down, et cetera. And I think that this can be helpful. So this is an example of something that you might actually find yourself doing. This came from a mental health clinic where they were doing exactly what we're talking about doing with you, and they decided what they were going to do. And this was kind of they weren't pretending. It wasn't imaginary, but they had chosen one part of their flow in this. It was in a psychiatric clinic. And so it's, so if you walk through it, and I know people are familiar with how a workflow works,
you know, it basically says who takes the blood pressure, what you do with the answer, you know, either it's okay or it's not okay. And if it's not okay, either way, where you document it. And in this case, if they have a PCP, then you've got to communicate with that person, and if they don't, then you have to find them one, and that would probably like connect you to the next workflow. But most important of all, the thing I want to point out most of all, and I've talked with some of you about this already, is that there's feedback loops. And so if you there should be feedback loops. Yeah, so if the patient, we assist the patient with establishing a PCP, and then we see them at their next visit, and we find out if they have one the next go round. And I think that if you have a workflow for physical health items, there should be lots of feedback loops. That's the feedback loop, the checking up, the making sure that it happened, the checking whether it was if the thing that happened was effective. That's what makes integration work. That's the extra kind of layer of oversight that we provide to patients who are being cared for elsewhere for medical conditions. An ideal, perfect primary care provider would provide that level of oversight, but the fact is, you know, our experience is that never works, or very rarely, and so that's why we have to have this extra layer, and so basically, if you're getting serious about how you're actually going to do these tasks, this is what you have to do. Now, it's possible that you could do this without exactly knowing who your team member is going to be. Without knowing what you're going to call them.
Okay, all right. Give them an interim name.
Right. Someone's going to be doing a procedure that involves getting a piece of information, sharing a piece of information, evaluating a piece of information, talking to somebody.
This is one of those places where I've seen a lot of workflows fall down because they do not establish accountability for who will do the task. You want to keep that, even if you reassign it later, it's okay, but if you don't assign it, it ain't going to happen predictably, right? So I just think of that as a kind of a key piece. Would you say a little bit about workflows you've developed, or I don't want to put you on the spot, but you raised your hand and said you've done some work? Sound okay? Thank you.
Workflows is my favorite nerd thing to do. So before we established our electronic health records, we mapped every single process in the agency. And we got together a team of front desk people, medical billing people, a clinical person, a program director, and we just met weekly, and we took one task at a time, from what happens if somebody hands $10 to somebody at the front desk, and mapped the whole process from the client's pocket to the bank. Or what happens if we discharge a patient? What's the paper flow? Who's responsible for it? What's the timeline? What if it's not a successful discharge? How does it change? So we did every process in the agency so that when we started working with the EHR, it was so much easier because we knew what our flow looked like. And it was fun.
That was a great cheerleading speech. Thank you. It was fun. Some of us do like it. Some of us dread them. So, other experience with that? Like every process?
Everything.
How long did it take?
Maybe 2 months.
Yeah. Okay. And who was on your design team?
Medical billing.
Yeah. Give them an example there.
Medical billing, the front desk people, clinical supervisors. And then what we did was we mapped the process, and then we handed it to somebody to do it. And that's where we would find a gap, like, well, where does this piece of paper go? Or what happened to the receipt to the client? What if we didn't get it? So we had to walk through it with the staff once it was done to make sure we captured it all. So it was time consuming, but it made things so much easier with EHR.
Did you diagram it or just outline it as a protocol?
Looks just like this.
Okay, great. Okay. So people use PowerPoint. Is a real easy, available tool for diagramming. Anybody else got something they've diagrammed to share, or? Okay. Sonia, want to talk a little bit about, she's cringing, but you all have had a lot of experience with workflow development that I think we can give to Annabelle or both of you. Whatever you want to do.
You want to specifically talk about workflow?
Yeah.
Okay.
A little bit about how you've dealt with that, or challenges and successes are fine.
So, actually it started from a BHT meeting earlier. There was an exercise, and it really spoke to us about how we need some workflows in-house just to understand our own mechanisms or processes. It is very time consuming, and you have to hook up everybody there, or you're running around tracking those who know, kind of thing. We also saw value that if somebody ends up not being there and they're the primary person who does that work, somebody has to come in and somehow figure out how it's done. And so having the workflow is a big part. So we're thinking about how this has to be part of a desk manual, essentially. So of course, the rub is having the time to do it, and for us, it's even having some expertise on how to do it well. Use diagram, trying to find a tool for that. We're still in the process of doing this, but we have a peer specialist that we recently hired who we could not use because she's waiting for her DOH credentialing, so there's just this downtime. And so we got excited and said, hey, can you just start doing these workflows? Questions? I mean, there's value to it, but it takes, like Kathy was saying, a lot of time.
Thank you, Annabelle. So it's important to have the smallest but effective team, because it's going to take a lot of time. You got to have everybody there, and you got to prioritize what are the main processes you have to organize first. Charisse?
A little bit about the workflow, because they work so hand in hand with the Newport Hospital, and so maybe how that added, or how that added to the workflow.
So you're assuming we're farther along than we are.
Lessons learned is always great.
We don't have workflows per se right now, but we have some processes. So we're taking like the Suboxone protocols that we have in place and recognizing that we need to fine tune them. Okay, and that's one of our provider plan kind of goals, in a sense, is that we're going to create this workflow to really fine tune the Suboxone program. I don't know if you want to talk more about weeds, Jennifer would be better about how we're currently doing it and where we're missing and why workflow would be very, very important, because some medical doctors are making referrals and some are not, and probably really establishing what the threshold should look like and who you actually contact and what happens if the person you're supposed to contact is not there. You want to add to that?
That sums it up. I mean, there's just a lot of breakdown in communication right now as far as the workflow goes. So that's definitely moving forward. A direction that we need to go is that bi-directional communication between the provider and the medical provider that's prescribing the Suboxone and us doing the treatment end of it, because right now there is a huge gap in communication. So we're finding out from the patients weeks later that they've been prescribed, and we're like, well, that's great to know. And then we're having to reach out to the prescriber to find out dose and everything else.
Right. I'm sure many of us have been there and done that one. Thank you for sharing that. Just a couple of ideas, like a workflow is usually encompasses a whole bunch of people's tasks, right? So you see MA, front desk, you see them all assigned on the workflow examples here. Maybe your providers need a pathway that's just theirs. A lot of people use the term workflow and pathway kind of interchangeably. I've been trying, I'm certainly not I'm not the expert on this, but where I see pathways, usually they're for one person, whether that's a prescriber or a care navigator or a care coordinator like the Pathways Hub program, where this is what you do. If you prescribed, you tell such and so, you enter it here in the EMR. So that might be a way to address that communication breakdown. So think about workflows and pathways differently. Sometimes you still got to get somebody to pay attention to it and use it, obviously, but that would be one thought there. Okay. So we've already kind of talked about that. We've probably put the fear of workflows in every one of you because everyone said how much work they were. So find your nerd, who likes to do this. People often use plan, do, study, act cycles for developing workflows. And really, that's what your team described a little bit. You outlined it, you tested it, and you looked for things that weren't working, and then you changed it up and improved it till it worked. Plan, do, study, act. That's a part of a model of care that primary care uses a lot. Not as many behavioral health agencies have had much time with this kind of structure. Plan, do, study, act. I know we're going to spend more time on that with Dr. Stott in the future. This is just sort of one of my favorite slides. I always have to say it when I say plan, do, study, act. It is not enough to do your best. You must know what to do and then do your best. It's really important to test your workflows. Test your pathways. Assign, for example, one provider to test it out and give you feedback, one front desk in your system, and beat it up and tweak it. If you roll it out prematurely, then think of all the miscommunication you're going to have to pull back within your agency and start over again with all your staff, right? So the more upfront you are is that we're piloting this workflow, this thing, at this place, right? We're going to get it right here, and then we're going to spread it to everybody else. Might look a little different, but we're going to spread it after we test it. So just keeping that in mind. That whole idea of I just sort of plan, do, study, act. What is it you're trying to do? What's the workflow? Can we get more info? I just made this up, right? You guys probably could make up much better ones than me that are pertinent. But that idea, what is it you want to do? How can we gather info at the front desk so we know more about their experience or relationship to primary care? Do they have a primary care doc? Are they established? I did this after our email exchange about, referrals and not always knowing. We make referrals to primary care, and it is often a black hole. And we don't have a feedback loop to tell us that there was a successful referral made necessarily. Sometimes we do, but sometimes we don't. So, what are we trying to accomplish? Get people connected. That's whole person care. You don't have to provide the care, but you will probably be asked more and more in your contracts to get people connected to and established with primary care. Not right away maybe, but it's the goal of whole person care is to have that coordinated system, right? And then looking for just a little bit of data. This doesn't have to be statistically significant data. It just means we tried it for the 5 patients at the front desk or 10 patients. Or we tried it for a day a week. And then we sat down with our staff who tried the new workflow, and they gave us feedback and said, this sucked. Or this took a whole lot more time than it should. So we really have to go back to the drawing board. So, getting it right, testing it and tweaking it up and getting it right. And then, of course, having just looking for those changes that are going to make everybody's workflow and providers' responsibilities a little easier. So, for example, in here, and I'm just Maybe you're doing this already, maybe you haven't thought of it, but but if you're already collecting that information as part of, while somebody's waiting around to go see their provider in an appointment, then maybe you can go ahead and alert your care coordinator or your care navigator to go ahead and start finding out where they've been seen, if anywhere before, get a little bit of history, alert the provider, and put in place those steps to start linking them to your primary care connections. Okay? That's just a little bit more on that. We're going to get you out early today, I think. That'll be okay. So I'm not going to go through all of this. It feels kind of like maybe a little too much. You've got some good concrete examples of workflow, and I actually think that's much more important, more concrete ideas to look at than this more theoretical model for improvement stuff. We're happy to provide that, but I'm feeling like at the tail end of a day where you've already worked pretty hard for all morning and for the last hour, I'm not going to walk you through this in great detail. Any other comments? Or PDSA is a great way to do this. Lean is another tool we can talk about later on another day if that's of interest. Do you all have QI staff involved or none? They don't exist in your organization. Can you say more about your level of how many of these tools might be new or not so new to you? New, not so new. I'm seeing some people. These are all tools that your primary care providers use extensively. So if we need to give you some more background on that, we're happy to. But these are the tools that primary care uses for all kinds of quality testing. Sometimes not as well as some other circumstances, but we'll want to make sure you know how to sort of speak this language. So final questions and thoughts about workflow development and how to go home and start, or throw some ideas out and see if people here or we have ideas for you. Dave?
I guess I'm going to end it back in Annabelle's question about money. So this is where I get stuck. If I take a clinician and I'm embedding in their clinic and we're establishing these workflows, I still have the reality that I have to pay that clinician. So if the patient has gone to see Dr. Tyson, he's providing a billable, reportable service. It has collected that person's insurance, and it is going to get paid for that. And now my clinician is called in to assist with behavioral health screening. I have to make sure that my clinician is also credentialed with that insurance panel, even if we're talking just with Medicaid. And I'm looking at what billable service, because the coordination makes perfect sense, but I literally don't know what CPT code am I going to have my bachelor's level case manager document in terms of the service encounter that they're doing for all of this excellent work. And that's where I'm stuck. If the person is coming to my clinic, then all of these services that we're providing, the PHQ screen, everything that we're doing, then it's occurring within a billable service that we're providing.
Right.
But to just take my clinician and to provide these consults, I'm stuck at what billable service are we doing?
Right.
And how am I getting that report to my insurance company?
I thought I'd ask you to feel that one.
So the
or
tough
ask
question,
for
the
other
person
thoughts.
from the back's calling in. No. I think that is absolutely legitimate. It's absolutely something that we hear from, I hear from each and every one of you, although I really like all of you. It's like, how are we going to get paid? And I hate parking. Those are the two things that, so you're near and dear to my heart. But you're absolutely right, and what it does for me is makes me think that we need, at some point in some forum, we need payers who are hearing that same exact question, and I'm sure you've presented it to them before. But so it makes me think that we being BHT and AIMS absolutely can't answer that for you. The people who can answer it for you, we need to get them here so that they can hear that, yes, we are trying our darndest to do integrated managed care. We're trying to wrap our arms around these people. The reality is we need to get paid. So how do we get paid for that?
So it literally forces us to have parallel tracks.
Yes, yes, yes. So, we've kind of thought about that already, and this gives more meat to it. And if we will do our darndest to address your question, get the payer, because at the end of the day, at the end of 2019, these experts, very smart people, can tell you all kinds of wonderful things. If you're not going to get paid for it, then you're going to send me hate mail about not only parking, but again, we're not getting paid, Cherise. So, and if at the end of 2019 you still say those two things to me, parking I can take, but if we didn't address really how are we going to get paid, how do we just sustain this financially, then I think personally BHT has missed a piece. So.
Great questions. Great. So, I mean, this sort of, we can outline what we think your needs are for a whole year, but it's these kinds of questions. And the one earlier today when we learned that pretty much a large majority here are looking at partnership strategies, aren't building their own. That really drive us to maybe bring that question to the fore earlier and sooner so that you can really, I think the MCOs in our state, for the most part, are happy to engage and support. If they hear what your models and how those are developing, I think they're happy to help us figure out more collectively how this fits. So, but yeah, nobody's got a quick and easy answer for you right now. A lot of the first embedded behavioral health clinicians in primary care were grant funded. Like folks like many of the FQHCs like Chaz were able to get large grants through HRSA, and then rather than hire their own BH consultant, they actually contracted some of those grant funds with a behavioral health agency to do it. So there's those kinds of contractual relationships that sometimes exist, but very hard to define here with money being as tight as it is and nobody being clear about the payment strategy in the long haul.
I had a question for you. The other organization on the other side who's asking you to do the coordination, this is it a hospital or is it a?
It's both. Yeah. Hospital, clinic, and state campus.
Yes, right.
Rural health clinic.
It's all rural health clinic. Right. Yeah, and so if they're asking you to do something that might conceivably be part of a medical side chronic care activity. So they can bill for the chronic care, the team-based chronic care, and if they're saying, well, we need you to be part of that, then you may say, we'll be happy to be part of that, and you can access our help for so many dollars an hour, something like that. And I think that a lot of the early collaborative care arrangements are of that kind, and I think that's perfectly legitimate to do and reasonable, and it serves everybody's interests.
Or comments or final words of wisdom? Yeah.
How are other regions doing this that are ahead of us?
No one's ahead of us.
Yeah, no one's ahead of us. Sonia asked, how are other regions doing that are ahead of this? I think there's huge confusion about this right now. And I think I've not seen a lot of clarity around, I've heard Cherise say this before, and I've actually quoted her. You have a much steeper curve than primary care does to get up to speed in this Medicaid transformation. There's so many more changes in your system than there are on the primary care side, but I don't have a sense that there have been a lot of clarity around that, and it's mostly going to come through the MCOs and MCO relationships, it seems to me. Tell me if I'm wrong, Cherise, but.
No, I
seems
think
to
you're
be where
right,
we're
and
going.
I certainly absolutely appreciate, again, the question and the feedback, and we absolutely know sustainability is a huge paramount issue. Kind of talking about Dr. Kern's question, though, spurred me. So we recently in Spokane saw a partnership between SNAP and CHAZ, where, and it's around the, help me, Sarah, it's around the diabetes, what is that called? The 8.
Diabetes prevention program?
So anyway, it's going to be all smart. I'm not smart. So CHAZ has certain patients that are diabetic, and they might come in for 1 or 2 appointments, and then they kind of fall off the bandwagon and they're not seen right. So those clients that are not engaging, that they just can't connect to, they will. They have an agreement with SNAP, and SNAP goes out literally to these people's homes, and knock, checks on them.
Does everybody know what SNAP is?
Yes.
Okay.
Thank you, Ann.
Okay.
Yes, you all nod your heads. You do know what SNAP means.
Okay.
And so that they literally do a warm, hi, how you doing? Are you doing okay with your diabetes? CHAZ is concerned. They then ask, do you have enough food? And if the person says, no, I don't have enough food, or maybe all they have are Cheez-Its and Diet Cokes, which is what Sarah eats every day, but we are better health together. Then that SNAP person will literally take that person either to the food bank if they don't have resources, or to the grocery store if they have, if they have money or food stamps. So, and they're making, again, that warm connection, and they report back to CHAZ. Yes, we saw Cherise, took her to the food bank, got her fruits and vegetables, talked to her about, what she needs to do to manage her diabetes and how critical it is. She makes it to her primary care appointment, at which point she says she has no transportation, and we kind of, how this scenario goes. But it was, and it is a interesting partnership where SNAP, it's my understanding, and we can maybe have them present at some point, where SNAP is getting a reimbursement from CHAZ to do that for that particular population.
So we're winding up on billing and sustainability, of course, because, well, we at Ames also work with the MCOs directly. And I guess we really want to hear any thoughts about models. Obviously there's the fee-for-service if you're credentialed, but there's also that direct contractual relationship that I know some primary care providers have with behavioral health, because remember, they also have their own new requirements to meet, and they want to be able to provide that many services more in-house than they do now with the embedded model. So no easy answers, but I almost feel like Cherise and Sarah and the rest of us have to maybe come back to you with a little clearer work plan on how we can maybe dig in a little deeper on what to expect from managed care sooner than later, and we're happy to help with that. So I can't promise we can move managed care, but we can always advocate. And the more you all have a more singular voice around what you want managed care to support, the more uniformity makes it easier for them, frankly, but it makes them more likely to agree, too. Other thoughts or final before we end for the day? Comments? No? All right. Any last wrap up, Cherise?
We'll send them on their way, but just
Okay.
real quick. So as you recall, the 4th Thursday of every month is our learning cohort. So in March, we will be focusing and looking at social determinant of health screening tools, as well as care compacts. And pretty exciting, we're going to have all partners in the room here, as well as our social determinant of health partners. So it's going to be a big room, a lot of folks, but I think that's really going to help, especially as we learn about the social determinant of health screening tools, you're going to have those actual partners in the room who might be able to be a referral source or a partner with you if you choose to go down that road. You have a bright orange survey feedback on your table. Please, you guys are always brutally honest with me, so I don't expect any different in that. But please let us know. I took notes as and Sarah and Ann did as well, but that continued theme about registries continues to pop up. So whatever it is that you need as we go forward, please indicate that, because we do read it, we do take it back, and we are continuing to develop and design these learning cohorts as we go forward. They're not set in stone. They really are dependent on your feedback and what your identified needs are. Okay? So with all of that, Dr. Kern and Ann will be with us for probably an hour longer or so. And so if you want to come up and ask them questions, you're more than welcome to. Give you some one-on-one time. And with that, I'll turn it over to Ann for one last parting word.
Right. We're also happy to do things between these monthly meetings. If you haven't, we heard registries a lot today, we're happy to put on just like an hour Zoom meeting where we can just show you various strategies and tools, whether it's spreadsheet, trackers, etc., answer your questions. We don't have to do that at this event. We got to start doing more work between learning collaborative events, or we'll never get you going. So we're happy to do that. Let Sharice know if that would be useful. That's something that I foresee we'll probably repeat 2 or 3 times this year. But if you're ready to hear about those things now, we don't want you to have to wait. Okay?
Yep.
So.
You guys are our bosses.
Yeah.
I think most of you know you're at least my boss by now.
Yeah.
So you need to tell us what you need. That's the end of the statement there. So really, really want you guys to drive home safely. Take care, and always wonderful to see you guys, sincerely. So thank you very much, and we'll see you soon. Thank you.
Thank you, everybody.